Good afternoon, Ganesh Prabhu sir. எப்படி இருக்கீங்க சார்? எப்படி இருக்கீங்க சார்? கணேஷ் பிரபு சார் கேக்குதா? அன்மியூட் பண்ணல நீங்க.
ரஞ்சித், குட் ஆஃப்டர்நூன்.
குட் ஆஃப்டர்நூன் சார். எப்படி இருக்கீங்க சார்?
நல்லா இருக்கேன். ஒர்க்கெல்லாம் முடிச்சிங்களா?
முடிச்சுட்டு வந்துட்டேன் சார். சீக்கிரம் ரவுண்ட்ஸ் ஓவர் ஆயிடுச்சு. சாட்டர்டே வெறும் கிளாஸ் ரவுண்ட்ஸ் தான் சார்.
ஓ அப்படியா? தியேட்டர் கிடையாதா?
சாட்டர்டே கிளாஸஸ் அண்ட் ரவுண்ட்ஸ். வெறும் கிளாஸ்.
ஓ ரைட்.
By 1:30 we'll wind up and come.
Okay. Good. சார் கணேஷ் பிரபு சார்
அவர் அன்மியூட் பண்ணல சார். இன்னும்
அன்மியூட் பண்ணுங்க.
Good afternoon, sir. Sudarshan, sir. Good afternoon. Unmute பண்ணல sir.
Yeah, good afternoon. Yeah, you made me a host. Ganesh Prabhu sir, please unmute yourself. ரஞ்சித், நல்லா இருக்கீங்களா?
நல்லா இருக்கேன் சார். நீங்க எப்படி இருக்கீங்க சார்?
நல்லா இருக்கேன். All well.
பார்த்தேன் சார்.
All right.
எல்லாமே பார்த்தேன். போது அந்த இது ப்ரோன் பொசிஷன் நல்லா பண்ணியிருந்தது.
பாத்தீங்களா?
ஆனா நீங்க 20 இயர்ஸ் முன்னாடியே அதுல நல்லா ஸ்ட்ராங்கா இருந்திருக்கீங்க போல இருக்கு.
Good afternoon everybody.
Good afternoon.
Good afternoon sir.
Good afternoon. Ranjit, how are you?
Fine sir. How are you sir?
வாழ்க வளமுடன். ஒரு ஆசீர்வாதம் பண்ற லெவல்ல பண்ணுங்க. ரெண்டு சிஸ்டம்ல you have joined?
ஆமா, ரெண்டு சிஸ்டம் இருக்கு.
Kripa?
Sir.
How are you?
Fine sir.
We have talked for a long time.
ஆமாங்க சார். ஆனா ஒரே ஒரு வார்த்தை தான் பேசிட்டே இருந்தோம் ரெண்டு பேரும்.
We have not talked for a long time. I have been talking to Sudarshan, but I could not get opportunity to talk to you.
இல்ல, நேத்து பேசணுமே. நேத்து ரெண்டு பேரும் ரொம்ப நேரம் பேசிட்டு இருந்தோமே.
பேசணும். அதுக்கு முன்னாடி சொல்றேன்.
நல்லா இருக்கீங்களா? சாப்பிட்டீங்களா?
நல்லா இருக்கேன். நான் இத்தனை நாள் டிராவல்ல இருந்தேன்.
அப்படியா?
நேத்து வந்து இல்ல அந்த டைம் வந்து இந்த டைம் ஆஃப் இது வந்து ப்ரோக்ராம் வந்து என்னோட டிராவல் டைம் ஆகுது, அவ்வளவுதான்.
ஓ ரைட். ஓகே.
நேத்துக்கு கரெக்டா அந்த டைம்ல நெட்வொர்க் ப்ராப்ளம் ஆயிடுச்சு.
ஓகே. 1 minute.
பர்சன் கேட்டாரு, சரி உடனே வந்துட்டேன்.
ஹலோ
ரஞ்சித், எப்படி இருக்கு உங்க ரா? எப்படி போகுது?
நல்லா போகுது சார். 2 ஸ்டுடியோ வேற போட்டிருக்கேன் இப்போ. ஒர்க் பயங்கரமா ஹெவி ஆயிடுச்சு. இங்கேயும் கரெக்டா கொரோனா முடிஞ்சு இப்ப சென்னை நார்மல் ஆயிடுச்சு. சோ ஒர்க்கும் பயங்கர ஹெவி ஆயிடுச்சு. ரெண்டு பக்கமும் மாட்டிக்கிட்டு முடிக்க வேண்டியதாயிடுச்சு சார்.
சரி. ஒர்க் நல்லா இருந்தா நல்லது தானே? ஒர்க் நல்லா இருந்தா நல்லது தானே? ஒர்க் இல்லாம இருந்தா கஷ்டம்.
கண்டிப்பா பிஸியா இருக்கிறது ஃபார் பெட்டர். ஐயோ லாஸ்ட் 6 months பட்ட கஷ்டம்.
ஒர்க் இல்லாம இருந்தா தான் கஷ்டம். ஒர்க் நல்லா இருந்தா இட்ஸ் வெரி குட்.
நல்லா ஆல்மோஸ்ட் நார்மலைஸ் ஆயிடுச்சு சார். இப்போ ஆல்மோஸ்ட் 3 to 4 கேसेस வந்துருச்சு. மேபி ஜான் we will have full இது. எல்லாம் அந்த 6 months லாக் வந்து இனிமேல் வரும் சார். பயங்கரமா இருக்கும்.
இனிமேல் செகண்ட் வேவ் வரும்னாங்க. அது வர்ற மாதிரி ஒண்ணும் தெரியல.
ஐஐடில கொஞ்சம் ஹெவியா வந்துருச்சு ஒரே இடத்துல. 220 ஸ்டூடண்ட்ஸ் ஒரே இடத்துல இன்ஃபெக்ட் ஆயிட்டாங்க சார்.
They will spread slowly.
அதுதான் பயப்படுறாங்க சார்.
It will happen. Eventually it has to go for a circle and then come back.
அங்க கோயம்புத்தூரும் கொஞ்சம் அதிகமா தான் இருக்குல்ல சார்?
கோயம்புத்தூர் எவ்ரிடே தியேட்டர் லிஸ்ட்ல வந்து 2 பேஷண்ட் பாசிட்டிவ் ஆயிடுது.
ஓ அப்படியா சார்? ஓ ஓகே.
நெக்ஸ்ட் டு சென்னை வந்து கோயம்புத்தூர் செகண்ட் ஹையஸ்ட்.
ஆனா சென்னை கொரோனா இருக்கிற மாதிரியே தெரியல சார். எல்லாம் பேக் டு நார்மல். எல்லாம் ரொட்டீனா மாஸ்க் இல்லாம ரோட்ல போறது எல்லாம் அப்படியே பழைய மாதிரி ஆயிட்டாங்க சார்.
ஆமா, கவர்மெண்டே எல்லாம் லிஃப்ட் பண்ணிட்டாங்கல்ல. ஆல்
ஆமா.
கேதரிங்ஸ் தே ஆர் அலோவிங். என்ன தே ஆர் அலோவிங் ஆல் த கேங்.
இப்போ இது பொலிட்டிக்கல் மீட்டிங்கும் தே ஸ்டார்டட் அலோவிங் சார்.
ஆமா, அலோவிங். ஸோ அப்படிங்கிறப்ப இட்ஸ் ஒண்ணுமே இல்லை அப்படிங்கிற மாதிரி ஆயிடுச்சு.
The Sivaprasad Selvakumar yet to come. As all the first hour delegates present has joined. Prabhakaran.
Yeah, I'm in I'm in the Zoom with the faculty. Yeah, okay.
ஹால் கோஆர்டினேட்டர் உங்களை கூப்பிடுறாரு.
ஃபோன் அடிச்சிட்டாங்க சார்.
அவர் உள்ள இல்லாம அவங்க வெளியில இருந்து கூப்பிடுறாரு பாருங்க. இதான் நம்ம ஆட்கள். குட்.
சங்கர் சார் வரல சார்?
இல்ல, அதான் பாக்குறேன்.
அதர் ஜட்ஜ்
சங்கர் சுப்ரமணியம் தானே?
எஸ் சார்.
வந்துருவாங்க. So we have 6 for the first hour. Just read out the
paper will be in the same order, no sir?
Same order. Vaishika, Deepa. Vaishika is here. Deepa, Dr. K. Deepa Kandaswamy. Yes. Then Roshni is here. Syed Mohammed.
சாப்பிட்டீங்களா?
Prabha, audio. Ram Nayak is there?
Ram Nayak and Syed are not there.
I don't see two of them. Anyway, they are all 4th and 5th. Niveta is there?
Niveta is there.
Right. Shankar. Tomorrow we have morning quite a busy program.
It's a morning.
Tomorrow morning the award papers followed by the...
Sir, on the award paper எல்லாருமே can log in, no sir?
Yes. We have given the link now. We have given the link. Everybody to join.
Yes sir.
சுதர்சன் எத்தனை மணிக்கு காலைல?
10 o'clock.
10 o'clock sharp.
உங்களுக்கு அனுப்பிச்சிருக்கேனே. I have sent you the link. Morning I have sent you.
சரி, பார்த்துறேன்.
இல்ல, பார்த்துருங்க. 10 o'clock.
ஓகே, அது வந்து இனாகுரல் செரிமனி மாதிரியா?
இனாகுரேஷன்னா சும்மா பிரீஃபா அவ்வளவுதான்.
நவீன் வராரு, முரளி வராரு.
அவங்க ரெண்டு பேரும் they are coming. They will give some brief address. one minute. Dr. Ramya, okay, we can hear you. Fine, we'll unmute you when your talk comes. Thank you.
Shilpa, are you there?
Coordinator.
Yes, sir.
Ramya, please.
Co-hosting Hall B and C.
Okay, sir. I'll tell them.
Because I am not able to.
Sure.
Shall we, Sudarshan?
Dr. Ramya. There is one Ramya who is presenting. One Ramya who is
ரம்யான்னு யாரும் இல்லையா சார் லிஸ்ட்ல?
இருக்குங்க, டாக்டர் ரம்யான்னு இருக்கு.
இல்ல ரம்யா இல்ல சார்.
இருக்குங்க.
4 பேர் தான் கொடுத்திருக்காங்க.
இல்ல அதுல இல்ல.
வசிகா, தீபா, ரோஷினி, சையத், ராம் நாயக், நிவேதா.
So in which case Ramya is the coordinator.
Sir, our judges are joined.
Yeah, okay.
Shankar.
Also joined.
Hello, sir.
Shankar?
Yeah, I'm audible.
Yeah, audible.
Good afternoon, sir.
We are not able to see you. Video.
Yeah, video is on only.
On only, yeah.
Shankar, good afternoon.
Good afternoon, sir. Sudarshan, sir.
We are ready.
Yeah.
I think we should.
Start, huh?
Dr. Ramya is
Good
here.
afternoon, sir.
Who are all the coordinators?
Dr. Ramya.
Shankar.
Sir. Good afternoon.
Ganesh Prabhu.
நல்லா இருக்கீங்களா சார்?
நல்லா இருக்கேன்பா.
Who are all the coordinators here?
Ranjit sir.
Ramya.
Good afternoon.
Dr. Ramya, she is a co-host already, but she is keeping very quiet. I don't know why.
Good afternoon, sir. Shankar sir. Good afternoon.
Good afternoon, sir.
The presenters are all ready.
And with your computer audio. A mic symbol is there, right? There, click on that one and yeah, your audio.
Yeah, she can. Dr. Ramya, I think you can carry on. Before that, Kripakaran.
Yeah, I am ready.
You're ready? Just a brief introduction and invite the guest, Dr. Ganesh sir.
It's the right time to start, no?
Yes.
Okay.
3:30.
Good afternoon, everyone. We welcome all of you for our second day program in Hall A. Yesterday program was very successful and it was went on very, very well in all three halls, and we received a lot of appreciation from all the delegates and judges. So we thank for all your cooperation, and without wasting much time, we will move on to our academic session. Before that, I want to invite our GC member, Dr. Ganesh Prabhu sir, to give felicitation address. Dr. Ganesh Prabhu sir, please.
Yes. Good afternoon, everybody. I am very happy to be a part of this PG Conclave. Really, I should congratulate TNISA Tamil Nadu for their excellent efforts to make this PG Conclave a great success. I think this is a program only for PGs, for the paper presentation, because ISA is conducting so many programs in various states regarding the PG assembly. But there will be lectures and PG program, paper presentation will be there. But this is exclusively for the PGs to present their papers. So it will be a very, very good, phenomenal effort by our Tamil Nadu ISA. So it should be congratulated. I should congratulate the team ISA Tamil Nadu for their great efforts. And I think really about 200 PGs are participating in this program. So it's a very new, very good number. So I wish this program a great success. Thank you. Thank you all. Thank you, everybody. Thank you.
Thank you very much, sir.
Thank you, sir. Thank you for your blessings. And tomorrow on the day 3, we are going to have a live presentation of all award papers in front of all the audience. So that will be more interesting for all the postgraduates and delegates. So don't miss that event. And tomorrow we are going to start the program at 10 a.m. So remember that. And after that, award paper presentation. We are going to have a career guidance program for the postgraduates. We note, we will move on to our academic session. Now I hand over this session to our coordinator, Dr. Ramya. Please take Dr. Ramya, please.
Thank you very much, sir. So hello, everybody. It's an immense pleasure to welcome you all to the TNISA PG Conclave 2020. I'm Dr. Ramya, Assistant Professor of Stanley Medical College in Department of Anesthesia. So the successful first day of the program, let's begin with the second day with the same enthusiasm. It's my honor to welcome the judges for the session. Dr. Shankar Subramanian is the HOD, consultant anesthetist and intensivist in SKS Hospital. And he has organized many programs like the Tamil Nadu State Conference AirCard 2015, as well as the Anesthesia Update Salem for the consecutive 3 years, 2016, 17, and 18, and also the SAP program in the 2019 in SKS Hospital. And with the second judge is Dr. Ranjit Karthikeyan. He's the professor HOD in Cardiac Anesthesia Department in Sri Ramachandra University. His area of interest is the pediatric cardiac anesthesia. He has almost published 52 publications as well as rendered 200 lectures and more. He's the examiner of the DM cardiac anesthesia, and he's also created the anesthesia website www.raaonline.co.in. Welcome, sir. Welcome, both of you. So as we are running on a tight schedule, let me introduce the candidates for the first session. Dr. Vaishika from Sri Venkateshwara Medical College, Tirupati. She'll be talking on the topic to study the clinical effectiveness of the bispectral index in the elective surgery with patients under general anesthesia. Second candidate is Dr. Deepa from KMCH Coimbatore. She's going to talk on the role of epidural blood patch in the spontaneous CSF leak. Third one is the Dr. Roshini from Narayana Hrudayalaya, Bangalore. She's going to talk on prospective cohort study of echo as an aid to the tracheal extubation in difficult to wean cardiosurgical patients. So, okay, good luck to you all. You can go on with the video. Thank you.
You can start, ma'am.
Good evening, everyone. My topic is to study the clinical effectiveness of bispectral index in elective surgical patients under general anesthesia, a prospective randomized study. Introduction. Bispectral index monitoring measures the depth of anesthesia and facilitates anesthetic titration to quantify the level of awareness. The bispectral index is an empirically derived algorithm that reflects the state of brain in relation to sedation. The aim of the study is to evaluate the clinical effectiveness of bispectral index monitoring and its relevance to hemodynamic parameters, drug consumption, and incidence of awareness in patients undergoing surgery under general anesthesia. Objectives: to study whether the incorporation of this in clinical practice for the management of anesthesia will reduce the risk of intraoperative awareness and recall in surgical patients undergoing general anesthesia. To study if BIS monitoring reduces drug consumption and recovery time in patients undergoing general anesthesia. To identify any risk or harm of BIS monitoring in patients undergoing general anesthesia. Methods. It's a tertiary care hospital-based prospective study, 1 year from the date of scientific and ethical committee approval. The study group consisted of adult men and women above 18 years undergoing various types of elective surgery under general anesthesia. 60 patients were included in this study. Adult patients with AASA physical status 1 and 2, aged 18 to 60 years, scheduled for different types of surgeries under general anesthesia, participated in this study. Patients were randomized for inclusion in the BIS handle anesthesia group, 30 members with the BIS control value between 40 and 60, which is considered convenient for surgical anesthesia, or the routine care group without BIS control, 30 members. A BIS sensor was placed on the forehead of the patients. Dosage of drugs used throughout the procedure was recorded. Hemodynamic specifications were recorded before induction of anesthesia and every 5 minutes during surgery until the removal of the endotracheal tube. The patients were questioned by the investigator at 24 to 36 hours after operation through the use of a structured questionnaire. Inclusion criteria: patient aged 18 to 60 years, elective surgeries of different types, general anesthesia. Exclusion criteria: use of beta blockers because beta blockers may mask fast heart rate, physical movements, or hemodynamic changes. Patients with traumatic brain injury, memory impairment, psychosis, or known or suspected EEG abnormality, which includes epilepsy, previous brain resection, patients with a history of mental disease, opioid addiction, neuromuscular disorders, sleep disorders, patients with history of awareness of the previous surgeries. Anesthesia protocol. Functional anesthesia system was checked thoroughly to reduce the risk of intraoperative awareness. Patients were pre-medicated with midazolam 1 milligram. General anesthesia was given, that is induced with fentanyl 2 microgram per kg, propofol 2 milligram per kg, intubation with cycloxanil 1 milligram per kg or vicuronium bromide 0.1 milligram per kg followed by maintenance therapy with oxygen, nitrous oxide, and sevoflurane. Heart rate, blood pressure, SpO2, intravenous and inhalation drug concentration, BIS, and clinical signs of lack of depth of anesthesia was continuously controlled and recorded. Bispectral index connected via electrodes to the patient's forehead and it is a signal derived from the EEG changes activity of the patient. BIS values ranges from 0 and 100. A BIS value of 0 indicates EEG silence. Close to 100, the patient is fully awake. Values between 40 and 60 indicates an adequate level of anesthesia recommended by the manufacturer. BIS signals near 100 at the start of surgery when the patient is fully conscious and falls to 50 after the induction stage when the patient loses consciousness, and it was maintained around 40 and 60 throughout the procedure. The BIS monitor allows the anesthesiologist to detect excessively high or low hypnosis and consequently to adapt the titration of the anesthetic agents to avoid unsafe states. Statistical analysis, the data was computed and all values were expressed as mean plus minus standard deviation. The data was analyzed using student independent t-test, NOR-test, chi-square test. Data were analyzed using SPSS version 20 and Microsoft Excel program. Results were tabulated and tables. This table shows the drugs used. This shows the incidence of awareness. This table shows the intraoperative awareness parameters, and this table shows the time to recovery findings. There was a statistically significant difference in the mean dose of inhaled anesthetic agents between the control group and the BIS group. BIS monitoring reduced the use of inhalational anesthesia. Regarding opioid fentanyl usage also, there was a significant difference between both the groups. In BIS control group, the usage of fentanyl was reduced. There was no significant difference in the propofol dosage. And meanwhile, the hemodynamic parameters also showed no significant difference between both the groups. Incidence of awareness in BIS group, there were no awareness reported. 4 reports in the control group. The most common form of awareness was auditory perception, tactile perception, and sense of paralysis. There was a significant reduction in intraoperational jerking in the BIS group. Conclusion, BIS guided anesthesia, where the BIS score is kept between 40 and 60, reduced the risk of awareness compared to routine care. The main reason for the occurrence of awareness in the routine care group could be due to light vein of general anesthesia. In addition, BIS monitoring reduces the usage of inhalational anesthesia, opioid consumption, and time to recovery. Thank you. These are my references. Thank you.
Thank you, Doctor.
Warm welcome. I am Dr. Deepa, presenting paper on spontaneous intracranial hypotension, role of epidural blood patch. Co-authors Dr. Aman Nandakumar, Dr. Sriram Kalingrayar, and Dr. Rohit B. Introduction to my topic. Intracranial hypotension is defined as an abnormally low intracranial pressure. It is characterized by posture-related headache. It occurs more frequently in women than in men, particularly among young and middle-aged individuals. No exact cause of spontaneous CSF leak has been yet proposed. Etiologies like pre-existing weakness of the dural sac, trivial trauma, spondylotic spurs, herniated disc has been proposed. As a result of CSF leak, intracranial hypotension occurs due to decrease in CSF volume rather than decrease in CSF pressure. The typical manifestation is orthostatic headache. According to the International Classification of Headache Disorders, this headache is dull and or diffuse that worsens within 15 minutes after sitting or standing, resolves within 72 hours after epidural blood patching, and with more than one of the following features: neck stiffness, tinnitus, hyperacusia, photophobia, nausea. The relationship between the course of SIH and epidural blood patching remains undetermined. Materials and methods. Clinical records of 4 patients who underwent epidural blood patch for SIH in the last 2 years were analyzed retrospectively. The diagnosis of SIH was made according to the diagnostic criteria in the International Classification of Headache Disorders. Brain CT and MRI images were examined by expert neurologists and neurosurgeons, and surgery was performed when needed. This chart depicts a summary of all my 4 case study. All had typical headache history. MRI and CT were used as imaging modalities. Epidural blood patch was done in the lumbar region, and all 4 had favorable outcome. First case, 32 years female with progressive headache and vomiting. In this MRI image, you can see thecal sac and extradural CSF fluid collection depicted by yellow arrow. Other findings are prominence of dural venous sinuses, diffuse mild pachymeningeal enhancement, extradural CSF collection. But the exact site of dural defect was not made out. In this MRI image, you can see pachymeningeal enhancement depicted by the blue box and subdural collection. Case 2, a 48-year female with throbbing headache history. In this image also, you can see the fluid collection depicted by the yellow arrow. Other findings are mild diffuse smooth pachymeningeal thickening, thin subdural hygroma, spine showed multilevel disc desiccation, disc protrusion, and subacute thrombosis in parietal cortical veins were seen. In this image, you can see pachymeningeal enhancement. Case 3 was a 32-year female with postural headache. She had a travel head injury while cleaning her house. In this MR image, the subdural collection and pachymeningeal enhancement is clearly visualized. Other findings were CT scan post-evacuation of hematoma showed residual collection, MRI showed minimal midline shift, and spine revealed diffuse dural laxity, extradural fluid collection, venous engorgement. Here also you can see the fluid collection. Fourth patient also had similar imaging findings. All 4 patients were treated with rest and analgesics initially. When the headache was not settled, autologous epidural blood patching was done in the lumbar region using 18-gauge Tochy needle. Post-procedure, patients were placed in Trendelenburg position for 45 minutes to 1 hour. This allows blood to travel along many spinal segments to reach the site of leak. Results of my study. Conservative methods did not relieve headache in all 4 cases. Epidural blood patching was done in all. In case 1 and 2, headache improved immediately after the procedure. In case 3, a 32-year female presented with history of headache for 10 days had chronic SDH. Surgical evacuation was done, but on postoperative day 1, she had persistent headache and a repeated MRI revealed in SIH. Neurologist opinion was taken, epidural blood patching was placed. Headache improved and she was discharged with a GCS of 15/15. Case 4, a 53-year female presented with chronic SDH. He responded initially to first epidural blood patching. He was asymptomatic for 2 months, after which he presented with increased headache history. MRI showed right frontotemporoparietal acute and chronic SDH and left parietal thin SDH. A second epidural blood patch was done, followed by surgical evacuation of hematoma. His headache improved and was discharged with 15/15 GCS. Discussion. The reason behind MRI changes is explained by Monro-Kelly doctrine. It includes diffuse pachymeningeal enhancement, engorgement and enlargement of the cerebral venous sinuses, collection of subdural fluids, pituitary hyperemia, and sagging of brain. Spine MRI changes include dural enhancement, extraarachnoid fluid collections, meningeal diverticulum. Thus, MRI has truly revolutionized our understanding of SIH. The usefulness of conservative management in SIH is negligible. Hence, epidural blood patch is now recognized as treatment of choice for SIH. It works by 2 mechanisms. First one is immediate effect related to volume replacement by compression of the dural sac as seen in my study. Patient's headache improved immediately post-procedure. Second, by sealing of the dural defect which has delayed role. The efficacy of epidural blood patches is 30%. Hence, sometimes patients may require more than 1 epidural blood patch. The initial blood patch is done in lumbar region regardless of site of leak. When non-targeted epidural blood patch attempts fail, targeted approach can be tried. At times, cumulative effect can be seen from multiple attempts. When blood volume of more than 22.5 ml is used, response rate was 80%. In general, tolerable blood volume is recommended. Thus, I conclude that epidural blood patch is a safe, minimally invasive, and very effective procedure. The response of epidural blood patch is highly variable, and there are no clear outcome predictors. When complications like SDH occur, surgical intervention is needed. But surgery alone can't prevent recurrence of SDH unless the site of leak is identified and sealed by epidural blood patch. These are references that I have quoted. Thank you.
Good evening, everyone. I'm Dr. Roshni, third year primary DNB student in Narayana Hridayalaya, Bangalore. My paper is titled Prospective Cohort Study of Echocardiography as an Aid to Tracheal Extubation in Cardiac Surgical Patients. My co-authors are Dr. Muralidhar Kanji sir and Dr. Anup Daniel Varghese. Introduction. Majority of patients receive mechanical ventilation electively following cardiac surgery till they achieve hemodynamic stability and blood gas homeostasis. However, a small proportion are ventilated for prolonged duration, which can result in significant morbidity and mortality. Transthoracic echocardiography can identify the cardiac origin of weaning failure, is what literature tells us. But very few studies has been done with all the echo parameters being taken into consideration. Objectives. Primary objective is to determine the sensitivity of echo parameters in predicting weaning failure. Secondary objective is to determine the most reliable echo parameter to predict weaning failure. Materials and methods. Study site is Narayana Institute of Cardiac Sciences, Bangalore. Study population is patients undergoing elective cardiac surgery. Study design, a prospective cohort study. Study period April 2020 to September 2020. Sample size based on expected sensitivity of E/E for detection of delay in extubation as 72%. The minimum sample size required is 390. Statistical methods, SPSS 23 version was used. Continuous variables were described as mean plus or minus standard deviation or median. Categorical data was represented as frequencies and percentages. P-value of less than 0.05 was considered statistically insignificant. Inclusion criteria, patient consent, 18 to 65 years of age group, elective open cardiac surgery. Exclusion criteria, patient refusal, minimally invasive surgeries, patients on ECMO and VAD, that is extracorporeal membrane oxygenation devices and ventricular assist devices. Re-explorations of cardiac surgery, patients who had periop hemodynamic compromise, episodes of sustained ventricular fibrillation or ventricular tachycardia post-op. Methodology, ethical clearance was obtained prior to the study, informed consent was taken. 400 sequential elective cardiac surgery adult patients were selected and managed as per institutional protocol by a blinded intensivist. Echo parameters were collected before the spontaneous breathing trial by a blinded echo technician of more than 5 years of experience. Patients extubated within 6 hours were considered as short ventilation. Those extubated more than 12 hours were considered as delayed extubation, and those extubated within 6 to 12 hours were considered interim ventilation. The parameters that were assessed were ejection fraction, regional wall motion abnormality, inferior vena cava collapsibility, pulmonary artery systolic pressure, tricuspid annular plane systolic excursion, E/A and E/E prime, which measures the diastolic function of the heart, right atrial pressure, wall function, presence of pleural and pericardial effusion. Results. The ejection fraction, the mean in short ventilation patients were 53%. The interim group also had a similar result, like 52%, but that in delayed extubation, the ejection fraction, the mean was found to be 38% only. The p-value was less than 0.001, which shows it is extremely significant, while in E/E prime, which measures the diastolic function of the heart, the short ventilation patients, the mean was 6, while in interim group also it was in a normal range, that is 7, but in delayed extubation, it was found to be abnormal with a mean of 9, and the p-value was found to be less than 0.001, showing it is also extremely significant. The other parameters were found to be insignificant. This is a graphical representation of the same. The sensitivity of E/E prime was found to be 87.5% with a specificity of 97.6%. The ejection fraction, the sensitivity was 85%, but specificity was only 55%. Discussion. Echocardiography has a significant role in diagnosing and monitoring patients in intensive care units. It provides information regarding the patient's suitability for extubation following cardiac surgery. Based on our findings in the study with the patients undergoing elective cardiac surgery, the echocardiography can be used to benefit the patient in terms of predictability of weaning the patient from the ventilator. In our study, we found that E/E prime has extreme sensitivity and predictability with regard to extubation success. Ejection fraction also helps in predicting weaning failure, but specificity is less than that of E/E prime. Conclusion. We recommend the use of echocardiography to aid extubation in cardiac surgical patients. It helps in identifying difficult to wean patients and hence better decision-making and postoperative management in these patients. It will improve the outcome of the surgery and benefit the patient. It improves further researches in this field. These are my references. Thank you.
Over to judges for the discussion.
Dr. Ramya, you may need to sort of wind up the session after 3 minutes, and you need to call. That's why I think you're there. I think over to the judges now. I think Shilpa has done that. Please, after every third presentation, you need to call the judges. I think you have the instruction given to you as a PDF. Please go through that so that we don't have any delay. And please call the next presenter once somebody has finished, so the next person will be ready to continue. Thank you so much. I think over to Dr. Ranjit and Shankar. Thank you.
Shankar sir, you can ask.
Yeah, Regarding the first presentation, Vaishika.
Good evening,
Am I
sir.
audible?
Yes,
Yeah.
sir.
It was a nice study has been done to prove that your BIS monitor reduces the opioid and volatile agent consumption.
Yes,
then
sir.
why it is not being used regularly in our practice?
So not every
Yes.
monitors have that BIS monitoring, sir. Only certain.
What are all the
workstations.
fallacies of BIS monitor? Why it doesn't get well as a depth of anesthesia monitor?
So it cannot be used in every patient, sir. Already patients who have some neurological impairment in those patients we can't use. Patients with old age patients may have dementia, so we cannot use in them. Elderly age group patients. Previous awareness, if the patients have previous awareness in those surgeries, they can't be used, sir.
But does the number holds good, 50 to 60?
40, yes,
the patient is always unconscious. And does it mean that above 60 or less than 40, they are either aware or more deep?
Yes, sir, it's reliable, sir.
It's not a reliable thing because it depends upon the other factors. Because this BIS is nothing but a EEG. It is being compressed and analyzed.
Yes, sir.
And this EEG disturbances depends upon so many factors like the drugs and the patient's sleep status. And even if they have any ischemic insult prior, all these things will have an impact on the numbers. So number cannot be said as it's a absolutely correct way of monitoring the depth of anesthesia. Even the patient who are on 40 to 60 had given awareness. That is the problem.
Okay, sir.
But it's a nice study.
Only two questions. Did you compare the hemodynamic parameters between the two groups?
Yes, sir. But there was no significant. So there was no significant difference. Every 5 minutes, I monitored systolic blood pressure.
Parameters are not described in the table which you have put.
Yes, sir. Because
so how did you adjust your hemodynamics to the inhalational agent? How did you measure the inhalational agent? How much is used and how did you measure?
There dial concentration in some workstations, and in some workstations, MAC was displayed, sir.
Okay.
According
so
to
how did
that,
you convert to that amount of inhalational agent with the MAC?
Sir, you're asking ML, sir, how to calculate. Sir,
so you said you use less amount of inhalational agent in the BIS group. I want to know how did you calculate the amount? Sir, just because of the dial was less or dial was more, you said that it is less. So you did quantify it.
Yes, sir.
Okay. Opioid, how did you measure? Depend on the amount of drug you gave.
Yes, sir.
So you didn't look at the heart rate and blood pressure, only at the BIS you looked at and you gave the opioid.
No, sir, I measured blood pressure parameters, sir. I didn't put on the table,
both group at the same heart rate and blood pressure, nothing was statistically significant. So what made you give the opioid? Only the BIS monitoring, is it?
BIS, according to the BIS values, I titrated and gave, sir. Significant difference in heart rate and blood pressure are seen only at particular time interval.
So that is the reason you have to put that tabular column.
Okay, sir.
Okay, sure. Second, Shankar sir, we can go to the second one, sir.
Yeah, second one.
Sir.
Thank you, ma. Regarding this spontaneous intracranial hypotension.
Good evening, sir. I'm Deepa.
Deepa.
Yes, sir. Good evening, sir.
Yeah. It was a nice thing, but the case, how did you select it? It was being given by the neurologist or the neurosurgeon?
It was discussed between the neurosurgeon and neurologist to whether to proceed first with epidural blood patching, and then after discussion, blood patching was done. So we have decided to proceed with blood patching.
You gave a list of 3 cases, no?
4 cases, sir.
4 cases, yeah. And
1 minute, Shankar sir. Shankar sir, 1 minute. Abstract shows 5 patients you have written.
One was we eliminated, sir. That I didn't mention.
But that was not mentioned in abstract. Yeah, go ahead. Go ahead, Shankar sir.
You said that patch was given. What was the space selected and how do you go by this? Because for our post-dural puncture headache, we select the space according to the dural puncture site. But in these all cases, there was a leak happening somewhere else, isn't it? So how do you select the space
It's
of?
if we are not identifying the exact site of leak, we can randomly go with the lumbar region first. If we if you are giving if you get the response means we can stop with it. If there was no response, then we can again analyze to proceed with second, or to look for second site for second line of management is to look for exact site for leaks.
Okay. So how much segment it will spread, giving a epidural blood patch?
Studies
what was
say
the volume
that
used?
Volume was 20 to 30 ml, sir. Studies say that approximately you can reach up to 8 segments, sir. More than 8 segments. If you'll get a good result with it.
Okay.
Said all conservative methods failed. So what all did you try?
Adequate hydration, rest, analgesics.
You tried?
Yes, sir. All the patients were first treated with conservative management, sir. Then only after analysis we have decided to take it for epidural blood patch, sir.
So you gave hydration and analgesic. That's it. That is the two conservative method you tried.
This epidural blood patch is a very rarely practiced even in our anesthesia side. So you had opened up a new door to the neurologist and other people to use this as a technique. So do you think that this will be a useful technique in the future?
Yes, sir. With
when we were
improvement
itself
of
not using it so much common in our practice.
Recently,
how common you use epidural blood patch for a headache, post-dural puncture headache?
When all the methods of conservative, all the conservative methods are failed, we can go for epidural blood patch, which is the last resort for post-dural puncture headaches, sir.
So what are all the steps you will ask your patient after performing an epidural blood patch?
Strict rest is must, sir.
How much duration?
Initially, after performing the procedure for 45 minutes to 1 hour, the patient will be made to lie in Trendelenburg position, that is head down position, for 45 minutes to 1 hour. Afterwards, by this time, their headache will start to reduce, and they'll be shifted to ward, and they'll be asked to take rest, sir.
So any other precautions you will ask them to take after giving a epidural blood patch? What advice do you give? So you should not ask the patient to strain more. That is more important.
Yes,
then second thing, you should always prescribe a stool softener. So they should not strain during passing of stools and other things. So all these precautions should be done.
Dufalac will be given, sir.
Okay.
Bowel movements will be analyzed.
Okay. Thank you.
Ranjit,
sir, anything else?
No, nothing, sir. We can go to the next.
Okay. The third presentation.
The third one, yeah. What is the name? Roshni.
Roshni.
No?
Roshni, sir.
Yeah.
Good evening, sir.
Roshni, what are the group of patients in the 400? All group of cardiac surgery included, is it?
All elective cardiac surgery patients I took, sir.
Elective means you included valve and CABG and
yes,
everything.
Sir. Yes, sir. But MVR, mitral valve replacement, I didn't include,
so
sir.
So the weaning of valve patient will be same as?
Mitral valve replacements I didn't include, sir, because that E by E prime values may not be correct. So that I have included.
You didn't put that in the exclusion criteria. Okay. Correct?
Yes, sir.
So you said 400 consecutive cardiac patient coming for surgery. Now you said you have excluded the patient who had come for mitral valve surgery.
Yes, sir. Actually, I included it in my protocols, and this slide I couldn't include. I forgot to include, sir. Sorry, sir.
So that is a very big mistake. Okay.
Yes, sir.
And other valve patients also you included, or only CABG, sir?
Other valve patients I included, sir. Aortic valve replacements I have included.
So you think aortic valve replacement and CABG weaning will be the same?
It's not exactly the same, sir.
How it can be the same? Okay. Then you said in ejection fraction 38% you will find it more time to win 12 hours. Okay.
Yes, sir.
What was the pre-op ejection fraction?
Pre-op it depends. I have included it in my master chart, sir. It was for some it was decreased after the procedure. For some it was the same, sir.
So that sum is very important, no? Whether the pre-op ejection fraction was normal or pre-op E bar E dash was comparable. Whether that developed in intraoperative period or patient was abnormal before.
Okay, both the categories were there, sir.
So obviously that might be the cause for reason rather than this one, no? The use pre-op P bar E dash might be low, no?
Okay, sir.
In your experience, you think parameters of LV will be difficult in weaning or parameter of right ventricle will be difficult in weaning from ventilation?
LV, sir.
LV? Mechanical ventilation affects LV badly or RV badly?
RV is a right ventricle, sir.
So, and on your parameter, TAP C, PA pressure, everything was absolutely the same. Is it correct?
That is the value I got, sir. That is one of the limitation of my study, sir. I couldn't do the echo.
You didn't put it as a limitation. And you said all the values, all the CVP, PA, TAP C, everything looks same. And in a valve patient, you can't expect the same TAP C like what you do in OpCap. Okay?
Okay,
so,
sir.
Then how did you do the echocardiogram in the postoperative period?
Sir, echo technician who had experience more than 5 years was assigned, sir. Because
here, experience doesn't matter. Cardiac surgery matters. Okay, you have done a surgery. There will be some collection around the heart. How did you get the image?
How did he get the image? Means I didn't understand.
Transthoracic, you can. It is easy to do in the postoperative period.
No, sir. No, sir. It is not easy. But in some patients, they had written the view is not, the window is not good. I have not taken them, sir.
You said 400 consecutive patients, and you think easy for do transthoracic in the 400 consecutive patients, particularly in valve surgery or in a high risk CABG?
No, sir.
These are my questions. Thanks.
Thank you, sir.
Yeah, Roshni, it was a good study. The thing is, weaning is something dependent upon multiple factors, not a single factor. As per your study, you are saying that the diastolic dysfunction is more prominent in our cases, and you are trying to project it as the main cause for the weaning failure. And as Sir said correctly, RV is more important in weaning a patient. That is a take-home point. And this echo-based weaning is mainly practiced in critical care units. And we have tried to do it in the cardiac surgical patients. But the main problem is getting up a window. So how you are going to get the window is the biggest problem. That is okay.
Thank you, sir. Thank you, sir.
Thank you, judges, and thank you, participants. Now for the next participants, I call upon Dr. Syed Mohammad Jassal from MMC Madras Medical College to talk upon prospective cohort study, a comparative study evaluating IV clonidine and dexmedetomidine on post-op recovery in cardiac valve surgeries. The second one is the Dr. Ram Nayak Malavatu from Madras Medical College. Is going to talk on dorsal penile nerve block for early ambulation in daycare surgeries in children year 2 to 5 years. The last participant is Dr. Niveta from Government TNI Medical College to talk on ultrasound-guided genicular nerve block for the knee osteoarthritis, comparing methylprednisolone and triamcinolone along with injection ropivacaine. Doctor, you can start.
I'm Dr. Syed Mohammad Jassi, postgraduate in Madras Medical College, Chennai. My paper is titled A Comparative Study Evaluating Intravenous Clonidine and Dexmedetomidine on the Postoperative Recovery Times in Cardiac Valve Surgeries. Coming to introduction, the use of intravenous sedation during cardiac surgery to reduce awareness is practiced routinely, and the effects of alpha-2 adrenoceptor agonists on postoperative outcomes are being continually evaluated. Clonidine is primarily an antihypertensive, while dexmedetomidine is primarily a sedative. The selectivity for alpha-2 receptors is relatively more with dexmedetomidine than clonidine. Both drugs produce central sympatholysis, analgesic properties without the risk of respiratory depression. Aims and objectives are to compare the effects of clonidine and dexmedetomidine on the postoperative recovery times in adult cardiac valvular surgery patients. The postoperative recovery times include the time to extubation and the length of stay in the postoperative ICU. The materials and methods. This is a prospective randomized clinical study conducted in 60 patients posted for elective cardiac valve surgeries in Rajiv Gandhi Government General Hospital, Chennai. Institutional Ethical Committee approval was obtained and patient informed consent was also obtained. 60 patients were randomly assigned to two groups. Group C with 30 people receiving intravenous clonidine 2 mg per kg bolus over 10 minutes, followed by 1 mg per kg per hour continuous infusion. While Group B, having 30 people, received intravenous dexmedetomidine 1 mg per kg bolus over 10 minutes, followed by 0.5 mg per kg per hour continuous infusion. The drugs were started 10 minutes prior to skin incision and continued till skin closure, and patients were followed up in the postoperative ICU. The study population includes people aged 20 to 60 years old, ASAPS 1 to 3, and surgery being elective with a valid informed written consent. The exclusion criteria includes patients not satisfying the inclusion criteria, patients posted for emergency surgeries, and patients with LV ejection fraction less than 40%, conduction abnormalities, allergic to the drugs used, and patients' refusal, and patients with respiratory, hepatic, renal, endocrine, neurological, and psychiatric diseases. The materials are 18-gauge Benflon syringe pumps, the drugs used for general anesthesia, with opioids being fentanyl or morphine, the volatile anesthetics being isoflurane or sevoflurane, use of clonidine or dexmedetomidine, the use of emergency drugs, vasopressors, vasodilators, the IV fluids like ringerlactate, normal saline. The monitors included ECG, non-invasive BP monitoring, pulse oximetry, central venous line, invasive arterial line, capnography, temperature monitoring, urine output, and arterial blood gas analysis. The weaning criteria were hemodynamic stability with no use or decreasing use of radioactive drugs, absence of significant bleeding, no significant arrhythmias, adequate urine output, and oxygen saturation more than 95% with an FiO2 less than 50%. Neurologically, the patient needed to be sufficiently awake to respond to commands. The sample size for the study was calculated from the software G-Power version 3. Demographic data were analyzed by students t-test, analysis of variance, Mann-Whitney U-test. All the results obtained have been discussed on a 5% level of significance. That is, P less than 5% considered statistically significant. And the results, there was no statistically significant differences as regards to the demographic data between the study two groups. That is, P was more than 0.05 in this case. And for the duration of postoperative ventilation and length of ICU stay, there was a statistically significant difference between the study groups. Here, the P value was less than 0.05. Coming to discussion, both duration of postoperative ventilation and length of ICU stay were significantly shorter in the dexmedetomidine group compared to the clonidine group. Afanador et al. Reported that intraoperative use of dexmedetomidine as a coadjuvant of fentanyl isoflurane-based anesthesia for elective heart surgery and adult patients could facilitate early postoperative extubation. Previous trials by Maldonado have shown that dexmedetomidine facilitates early discharge of patients from the ICU following cardiac surgery. Fast-track anesthesia techniques that facilitate early tracheal extubation has been associated with better postoperative hemodynamics, lower postoperative incidence of atrial fibrillation, lower postoperative respiratory infections, and reduction in care costs and optimization of hospital resources. The intraoperative use of dexmedetomidine has a better efficacy than clonidine in reducing the duration of postoperative mechanical ventilation and shortens ICU stay in patients undergoing cardiac valvular surgeries. These are my references. Thank you.
Good evening, everyone. My topic for presentation is dorsal nerve block for early ambulation in daycare surgeries in children of 2 to 5 years age group. Introduction: circumcision is one of the most commonly performed surgeries in daycare pediatric surgeries. The estimated prevalence for the circumcision is around 13.5% in India. There are different methods available for alleviating the post-operative pain and to reduce the complications, which include caudal epidural block, dorsal nerve block, ring blocks, and non-steroidal anti-inflammatory drugs and or topical analgesia. Dorsal nerve block has proven its effectiveness for post-operative pain relief. In our study, we investigated if penile block could aid in early ambulation to reduce the incidence of post-operative complications such as nausea, vomiting, hematoma, and urinary retention when compared with the caudal analgesia. Methodology: 62 boys of American Society of Anesthesiologists, physical status 1, belonging to the age group of 2 to 5 years, presenting to the OPD for elective circumcision, were subjected to an prospective observer-blinded randomized control study where the children were divided into 2 groups, where the first group received a penile block with 0.25% of bupivacaine at the rate of 1 ml per kg with ring block, and the other received caudal block with 0.5 ml per kg of 0.25% bupivacaine. Post-operatively, sedation scores were measured with Ramsar sedation scores. The results of post-operative motor blockade were observed with Bromage scoring, and incidence of post-operative complications like nausea, vomiting, hematoma, and urinary retention were measured. Coming to the results, there are no post-operative complications observed in either of the groups. There was significant difference in the mean Bromage scores between caudal block and penile block as measured by the Friedman test with a p-value of 0.0001. Sedation scores were better in the penile group, where 100% of the boys returned to their preoperative conscious levels within 180 minutes of the surgery, while it took around 300 minutes for the same in children receiving caudal epidural block. However, this was not statistically significant as measured by the unpaired t-test. We got a p-value of 0.97. Here you can see the pink represents caudal, whereas the purple represents penile block. The mean scores and mean Bromage scores in penile block were 1 because it doesn't cause any post-operative motor palsy. And coming to the sedation scores, we observed the children for 6 hours post-operatively, and the children in caudal block took around 5 hours or 300 minutes to come to their previous preoperative conscious levels. While in the dorsal nerve block, it's almost around 3 hours or 180 minutes. Summary: compared with caudal block, penile block has less Bromage scores since it doesn't cause any motor palsy. Also, it aids in early ambulation and mobilization in the post-operative period after dorsal nerve block, and better parent satisfaction is present than the caudal analgesic block. Furthermore, none of the children developed any post-operative complications in either of the techniques. Hereby, we conclude that dorsal penile block can be used for daycare surgeries with an equal effectiveness caudal epidural block, but with lesser hospital stay than caudal block. Thank you.
Good morning. I'm Dr. Niveta, doing second year postgraduate in Government TNISA Medical College. My paper is on ultrasound guided genicular nerve block for knee osteoarthritis, comparing methylprednisolone and triamcinolone with ropivacaine. Chronic knee osteoarthritis commonly affects elderly population that is characterized by severe joint pain, disability, and joint stiffness, which is the leading cause of disability worldwide. So in spite of multiple pharmacological, non-pharmacological treatment modalities that is available, adequate pain relief is still not achieved. So my study aim is to assess the efficacy of comparing triamcinolone methylprednisolone acetate with local anesthetic during ultrasound guided genicular nerve block for knee osteoarthritis. So after assess the eligibility of the patient based on inclusion and exclusion criteria. Inclusion is ASA 1 to age 40 to 70, both males and females, and from grade 2 knee osteoarthritis and pain duration more than 2 months. While the exclusion criteria is ASA 3-4, patient with prior knee surgery, BMI more than 35, patient with connective tissue disorder, patient with steroid injection for the past 3 months, and patient on anticoagulation medication. So after the patient is selected for eligibility, after getting informed consent, the patient is randomized into 2 groups, Group A and Group B. Group A patient receives 6 ml of 0.5% ropivacaine with 60 mg of triamcinolone as a whole, and Group B patient receive 6 ml of 0.5% ropivacaine with 60 mg of methylprednisolone acetate as a whole. So genicular nerves is actually a complex group of nerves that arises from 3 major nerves like sciatic, femoral, and obturator that mainly provides a sensory supply to the knee capsule, which is responsible for pain. My study is a randomized prospective double-blinded study. So before procedure, no pre-medication or sedative needed. The patient was asked to stop all the analgesic medication they were taking. So patient is placed in the supine position with pillow under the popliteal fossa to alleviate any symptoms. And after the proper positioning, the parts are painted and draped, and a high frequency lean probe is placed parallel to long bone shaft, and it is moved up and down to identify the epicondyles of the long bone as shown. So once the epicondyle is identified, the genicular arteries were identified near the periosteal area, which is the junction of the epicondyle and the shaft of either femur or tibia. This is the pulsation of the genicular artery. Accordingly, the genicular nerve block target point should be next to each genicular artery, because superior lateral, superior medial, inferior medial genicular artery that travel along with the genicular nerve. Here, the inferior lateral area alone is spared because it is associated with peroneus muscle weakness, which is responsible for plantar flexion and eversion of foot. So after confirming the artery location, needle is inserted and tip is placed next to genicular artery. After gentle aspiration, the group A patient received 2 ml of 0.5% ropivacaine with 20 mg of triamcinolone at each site, and group B received 2 ml of 0.5% ropivacaine with 20 mg of methylprednisolone at each separate site. So this is the image. This is the video that's showing a spreading of the drug after injected over the periosteum area, covering the genicular artery along with genicular nerve. So before procedure, the patient was instructed to use a VAS score and an Oxford knee score. This Oxford knee score was based on a self-administered joint-specific 12-item questionnaire regarding a joint movement while performing daily activities like able to washing coats or able to walk down or climbing upstairs, etc. Each question was scored from 1 to 5, and the total score was summed up to 12 to 60, with 12 representing the optimal outcome. And the grading comes like this: like score 0 to 90 is poor, 20 to 29 moderate, 30 to 39 good, and 40 to 48 is excellent knee function. Coming on to the result, the first VAS score, group A patient, the baseline VAS score was noted, and immediately after was also noted. So group A patient baseline VAS score is 7.8 and group B is 8.1. Immediately after genicular nerve, it was drastically reduced to 2.8 and 3.2, but no much difference between the both groups. Onset of action that was taken from the third injection site, from the third point of injection. So the group A patient, it is 122.35 and group B is 117 seconds. Duration of action is 12 days and group B it is 15 days. And the Oxford knee scoring before genicular nerve block for group A is 37.1 and group B is 37.6. And in post procedure, it is 30.1 and 29.7. So comparing all the results, there is no any much drastic difference between the parameters that is in my study. So between the two groups. So my p-value is more than 0.05 for all the parameters, which is statistically not significant. So concluding my study, while considering pain relief was achieved in all patients, the efficacy of both the drugs in chronic osteoarthritis are similar. Thank you.
Thank you, doctors. I request the judges for the discussion part. Since Dr. Ram Naik has not turned up today, we are having Dr. Sayed Mohammed and Dr. Niveta for the session. Over to you, judges.
Ranjit sir. Hello.
Yes, sir.
Hello.
Yes, sir.
Ranjit sir.
Yeah.
Oh.
Dr. Syed, it was a very good
Good
study.
afternoon, sir.
What made you to compare? What made you to compare clonidine and dexmedetomidine?
Basically, both are having the same mechanism of action and having the same mode of, analgesia and sympatholysis effects in alpha-2 receptors. So I thought which low-cost drug clonidine can be compared against a little expensive drug dexmedetomidine in seeing the effect of post-operative recovery times.
So dexmedetomidine is better or clonidine is better?
In my study, I found dexmedetomidine to be better, sir.
So this is anything new about it, or it is the same? It is well known, or it is a new concept, whether dexmedetomidine is better than clonidine?
It's a generalized concept that dexmedetomidine is better than clonidine, sir, but there has been no direct comparison otherwise.
Can you tell there is no comparison between clonidine and dexmedetomidine? That's what you're telling.
Particularly in cardiac surgeries, there has been comparison between propofol and dexmedetomidine, but clonidine and dexmedetomidine, the literature is very less.
Literature is very less, or literature is not there?
Not there, basically. When I searched, I could not find any literature.
Okay. What made you to put only 30 patients? What statistical analysis you do to get 30 patients only?
From the sample size calculation, using the.
How did you calculate it?
Using the formula for the alpha, keeping alpha as 5 and power of the study as 80%.
Any pilot study or any previous study you had to determine the number of patients?
Yes, in previously study had compared 30 patients. It was a duration of 2 years study by Kashmir.
What was the study
then? Just a comparison between propofol and dexmedetomidine, sir, in annals of anesthesia essay online, sir.
So you use that study to compare dexmedetomidine with clonidine here?
Yes, sir.
Okay. Yeah. What type of cardiac surgery you used it here?
I'm mainly using only on cardiac valve surgery, sir. Mitral valve replacement, aortic valve replacement, and a double valve replacement, sir.
So these are the two cases, valve surgery only used the dexmedetomidine?
Yes, sir. Only on exclusively on pump valve surgery, sir.
Sure. Thanks. Thanks, Shankar, sir.
Thank you, sir.
Yeah, you said that dexmedetomidine seems to be a superior thing.
Yes,
what action does the dexmedetomidine has on the cardiovascular?
It causes profound bradycardia and hypotension, sir.
Apart from that, there is a known complication.
Yes, sir.
Anything else on the pulmonary artery pressure? Being you're using it in the cardiac surgery, you should know what is the action on the pulmonary artery pressure and other things. No.
Yes, sir.
So you please refer it. Okay.
Yes, sir.
It's more important. Huh?
Yes.
Good study, man.
Thank you. Thank you, sir.
So sorry for the interruption, sir. Dr. Ram Naik is also available for discussion.
I was wondering whether you missed it out.
Yes.
Ram Naik is there?
Dr. Ram Naik?
Actually disconnected. I think we can go with the next Dr. Niveta.
Yes.
If he joins back, then I'll tell you.
Sure. Thank you.
Niveta.
Good evening, sir.
Am I audible?
Yes, sir, audible, sir.
This is once again a study in the Department of Orthopedics. So
Yes,
you entered to give pain relief for the osteoarthritis, isn't it? Okay.
Yes, sir.
So you said that you're saying that the knee pain in osteoarthritis is mainly due to the capsule problem,
No,
and
sir.
any other nerves are involved.
It may also come from the articular surfaces also, sir. So majority for acute pain relief, the pain is mostly from the capsule of the joint that is supplied by the genicular nerves. So I have chosen to block these genicular nerves with injection, local anesthetic with steroids, sir.
Okay.
What is the aim of your study?
So my aim is mainly pain relief for OENE patients, sir. By using both steroids with local anesthetics, sir.
See, your aim is to compare the steroids, or you want to compare the pain relief?
No, sir. My aim is to compare the steroids, sir, in pain relief.
Okay. Is triamcinolone and methylprednisolone dose was equipotent?
Yes, sir, equipotent, sir. 20 mg of triamcinolone is equipotent to 20 mg of methylprednisolone, sir.
You are sure?
Yes, sir.
What is the normal dose of methylprednisolone used?
Sir, normal, it can be used up to 80 mg, sir.
Okay. Yeah. Anything else, Shankar sir?
Did you have the follow-up of these patients for how many months?
Yes, sir. Sir, it's an ongoing study. So I have followed these patients for 1 month, sir. Through phone calls, I have followed these patients, sir.
So how much? What was the difference? It doesn't mention about that.
Sorry, sir.
It doesn't mention about the analgesia point of view.
Yes, sir.
Among the two
Sir,
steroids.
Among the 2 steroids, there is not much difference between the pain relief, sir. Both the group of patients have same effect of pain relief and also equal duration of pain relief, sir. There is no much difference between both the groups.
And selecting the patients for these, it was being done after the orthopedician saw the patient and sent it to you, no, for the procedure.
Yes, sir.
So why
They died.
Why do you want to have the inclusion criteria as ASA 1 and 2, excluding 3 and 4 and all? After all, it is an ultrasound procedure and you are not planning for any anesthesia. Why do you want to have that as an inclusion criteria and exclusion criteria?
Sir,
because anyhow, these OA patients are going to be having so many functional limitations.
So I don't want the patient with major abnormalities to be included in the study, sir. So I have just included as ASA 1 and 2 and excluded ASA 3 and 4 patients.
Okay. Thank you.
Yes, sir. Thank you, sir.
Nayak is there or?
Sir, unfortunately, he can't make it to the session.
So what we have to do for him? He has presented the case, but he is not taking the answer. Maybe Selvakumar sir can say something.
Yes, sir, sure.
Yes, I'm here.
Yes, sir. He presented and he went away, sir.
Yes, sir. Somebody in his family has suddenly become ill, so he has to leave. Just you take him out from the consideration for the best paper or something like that.
But we can give the mark for the presentation.
Next, yeah. The other columns you can present. Naturally, the marks will be low.
Okay.
I cannot do anything. I cannot help.
Okay. Sure. Thank you, sir.
Thank you.
Thank you, Shankar sir.
Thank you, sir. Thank you, Ranjit sir. Thank you,
Thank you, sir. Thank you, both of you, sir.
Sure.
Thank you. Thank you so much.
Okay.
Thank you, Krupa sir.
Sir, you can send the score sheet to Dr. Edward Johnson through email,
sure,
sir.
We'll fill it.
Okay.
Thank you, sir. Thank you so much,
Thanks,
sir. Okay. So we can go for the next session, which will be hosted by Dr. Senthil Kumar from Madurai Medical College.
So am I audible? Am I audible?
Yes, sir.
Yes,
Audible.
Yeah. Thank you. Good afternoon, everyone. I am Dr. Senthil Kumar, coordinator for this session. Thank you, Dr. Ramya and judges, Dr. Ranjit and Dr. Shankar Subramaniam and presenters. And make the session in lively and useful manner. Now we move on to next session. We glad to invite our judges, Dr. Ganesh Prabhu sir and Dr. Prasanavadhan sir. Dr. Ganesh Prabhu sir is now professor and HOD of Velamal Medical College, Hospital and Research Center. He is our teacher and former professor, director of IOA, Institute of Anesthesiology, Madurai. He is a true ISAN, currently holding the post of Governing General Member, National ISA. He is a past secretary, Madurai City branch, as well as Tamil Nadu State branch. Even though many credential, best one is we had conducted the national conference in 2014 under his leadership, one of the unforgettable national conference. And I can say many things about him, but for time not available, I can move on to next judge, Dr. Prasanavadhan. Welcoming sir. He's a professor of anesthesiology. Vinayaka Mission Medical College, Karaikal. His area of interest, interventional pain management, regional anesthesia, and ultrasound applications. His anesthesia cartoons are very popular among anesthesiologists and medical fraternities. And also his power presentations are very good and liked by most of the anesthesiologists. Now, I welcome you both, sir, both our Professor Ganesh Prabhu sir and Prasanna Nathan sir. And I move on to session. First start with Dr. Vanasuma Gowda, please.
I thank Tamil Nadu ISA PG Conclave for providing this opportunity to present my paper on intrathecal 1% 2-chloroprocaine versus 0.5% bupivacaine for patients undergoing saddle block and daycare surgeries in terms of recovery and home readiness. Myself, Dr. Vanasuma S.R. Gowda. Why we decided to conduct this study? Because India being highly populous with acute shortage of healthcare facility with adequate availability of surgeon, daycare surgeries can play better role. But the main challenge is selection of ideal local anesthetics for spinal anesthesia in daycare surgeries. So until recently, bupivacaine was the most obvious alternative, causing unacceptable delay in home discharge because of prolonged duration. Local anesthetic with short duration of action like preservative-free chloroprocaine has revived interest for spinal anesthesia technique in short and ultra-short daycare procedures. So we conducted this study with an aim of comparing 2-chloroprocaine with bupivacaine in patients receiving saddle block for perineal surgeries on daycare basis in terms of recovery and home readiness. Our primary objectives were to compare both study drugs with respect to time taken to obtain discharge criteria from PACU to post-operative ward and to assess time taken for obtaining discharge criteria from hospital to home. Our secondary objectives were time taken to unassisted ambulation and micturition, and also to know if there are any complications in the post-operative ward or during after getting discharged from hospital. This is a randomized double-blind parallel group clinical study initiated after obtaining clearance from the Institutional Ethical Committee, conducted over a period of 12 months. We included all the patients belong to ASA class 1 and 2, aged more than 18 years, less than 60 years, and who are posted for elective perineal surgery of duration less than 60 minutes. And patients who have allergy to study drug and patients who have contraindication to spinal anesthesia were excluded. So initially 104 patients were assessed, out of which 100 were chosen, randomly divided into Group C and Group B. Group C patients, all the patients were included, and in Group B, one patient was excluded because of block failure. Group C patient received intrathecal injection of 1% 2-chloroprocaine 40 mg. Group B patient received 0.5% hyperbaric bupivacaine 1.5 mg intrathecally. So after completion of surgery, all the patients shifted to PACU, assessed every 5 minutes using modified Aldred scoring system, and total duration of stay in the PACU recorded. After achieving Aldred score of 10, patients were shifted to post-operative ward, assessed every 30 minutes using post-anesthesia discharge scoring system. So time to unassisted ambulation micturition was also recorded, and also time taken to obtain discharge eligibility from the hospital. That is time of injection of study drug to the moment patient attained all the discharge criteria was recorded. The sample size was calculated based on previous study conducted by Mary Andre where mean time for discharge eligibility was taken as one of the variable. With 80% power, sample size was around 47. So considering the dropout rate, we included 50 patients in each group. So all the continuous variables represented as mean plus or minus standard deviation, categorical data represented as absolute numbers or percent, descriptive data calculated using chi-square test or Fisher exact test, and independent t-test was used to compare other variables like time of length of stay in the PACU or time to obtain eligibility criteria from hospital to home. So all the demographic variables were comparable in both the groups. Baseline vitals were also comparable, and all the vitals recorded in the intra, post-op and PACU stay was comparable in both the group. Time spent in PACU
was 105 minutes in group B, and it is 27 in group C patient, and it was found to be statistically strongly significant. And mean time to attain discharge eligibility from hospital was also strongly significant, and it is significantly shorter in group C. And time to unassisted ambulation was 243 minutes in group B and 144 minutes in group C, and it is statistically strongly significant as p-value is less than 0.01. And time to micturition and time to ambulation was also strongly significant, and it is found to be shorter in group C patients. And time to peak block height was strongly shorter in group C patients compared to group B, and duration of sensory and motor block was significantly longer in group B patients compared to group C, and duration of surgery was comparable. And none of the patients in both the study group required additional analgesia in the intraoperative period, but group C patients experienced more pain. That is 26% of the group C patients experienced more pain in the postoperative ward compared to 4% in the group B. One of the patients in group B, while 4 patients in the group C experienced nausea, vomiting, but it is statistically not significant. Coming to the discussion, dose selection was done according to previous study conducted by Ben David et al. And Kobax DJ et al. And sensory block regression was 2.4 times faster in 2CP as compared to the bupivacaine, and significant difference of 78 minutes observed between two groups with regard to time taken to obtain discharge criteria from PACU to postoperative ward. As with the time taken to attain eligibility from hospital, a significant difference of 83 minutes observed between two groups, and a statistically significant difference of 99 minutes and 85 minutes observed between two groups with regard to unassisted ambulation and voiding respectively. So limitations, it is not perfectly blinded because of earlier and faster regression of block in 2CP group. The blinded observer could guess to which group the patient belonged. So to conclude this study, we found that saddle 2-chloroprocaine 40 mg provides satisfactory anesthesia for perineal surgery lasting less than 1 hour, and spinal 2-chloroprocaine when compared to low dose bupivacaine resulted in faster regression of the block and early ambulation and micturition. So these are my references. Thank you.
Thank you.
Good afternoon, everyone. I'm Dr. Rashmi Hecha from Adis Junchingiri Institute of Medical Sciences. My registration number is 0027, and today I'll be presenting a paper on comparison of postoperative analgesia with transversus abdominis plain block and intravenous paracetamol in patients undergoing lower abdominal surgeries under subarachnoid block. Coming to the introduction, providing postoperative pain relief is essential for good recovery of the patient. Intravenous paracetamol therapy is simple to administer, whereas TAP block is a skilled procedure. Transversus abdominis plain block is a facial plain block between internal oblique and transversus abdominis muscles, providing postoperative analgesia in abdominal surgeries. The present study is undertaken to know whether TAP block is superior regarding the duration and quality of analgesia compared to paracetamol therapy. The methodology used is as follows. A prospective double-blind randomized study was conducted after obtaining Institutional Ethics Committee approval. 62 ASA 1 and 2 patients of age group 18 to 60 who were posted for various lower abdominal surgeries under subarachnoid blocks were taken up. They were randomly divided into two groups, Group TAP and Group P, by enclosed envelope method of 31 patients each. Patients who had history of allergy to local anesthetics and associated medical problems were excluded. Group TAP received 15 ml of 0.5% of ropivacaine injected on either side of the abdomen under ultrasound guidance at the end of surgery, whereas group paracetamol received 1000 mg paracetamol infused 8 hours after the surgery. The patients were evaluated for pain at rest and for movement using VAS score at 2, 4, 6, 9, 12, and 24 hours by an investigator blinded to the allotment. The rescue analgesic in the form of IV tramadol 2 mg per kg body weight was administered if the VAS was more than 3. Coming to the technique of TAP block, the procedure was performed after taking aseptic precautions. A linear ultrasound probe of 11 MHz was placed transversely on the anterolateral abdominal wall between the iliac crest and costal margin of the ribs. Using ultrasound, the 3 layers of the abdominal muscles, the external oblique, the internal oblique, and the transversus abdominis, identified. A Quincke Babcock's 22 gauge 10 cm attached with flexible tubing to a syringe filled with normal saline was introduced through the skin anteriorly in the plane of ultrasound beam and advanced into facial plane between the internal oblique muscle and transversus abdominis muscle. 2 ml of the normal saline was used for after careful aspiration to exclude vascular puncture, focusing on direct visualization of an expanding plane under ultrasound. The tap block was then performed on the opposite side with similar step and depositing 15 ml of 0.5% ropivacaine. After each 5 ml bolus, patients were monitored for an increase in heart rate or signs of local anesthetic toxicity. The patients were shifted to recovery room post-procedure and were monitored. The statistical analysis was done using independent t-test and Mann-Whitney U-test, and the data was analyzed using SPSS software version 17. Here's a table depicting comparison of median VAS score between study groups at various time intervals at rest, which shows that comparison of median VAS score on movement in study groups at different time intervals. As you can see, group TAP, the median was much less compared to group B. The first graph shows time in hours for first analgesic, which is significantly reduced in group B compared to group TAP. The second graph shows total tramadol consumption in 24 hours, which is significantly higher in group B compared to group TAP. The results were as follows. Paracetamol group had more pain on movement at rest when compared to TAP block at all time intervals. Patients who received TAP block had significantly reduced 24-hour tramadol. The mean time to first requirement of tramadol was significantly longer in patients who received TAP block. Coming to discussion, the results of our randomized double-blind study showed that TAP block provides effective and prolonged analgesia, delayed time for rescue analgesia, reduced requirement of tramadol when compared to IV paracetamol. We use the USD guided technique where we visualize the needle in the TAP space and accurate deposition of LA. It reduced the complication which was more common in a blind or anatomical approach as seen by Farooq et al. In 2008 where there was hepatic injury. In another study conducted by Bhanu Lakshmi, compared ultrasound guided transverse abdominis plane block with intravenous diclofenac for postoperative analgesia in elective LSCS, they concluded that TAP block provided effective analgesia and significantly decreased the requirement of opioids, which is in concurrent with our study. I conclude by saying that TAP block requires ultrasound and technical skill to administer. TAP block provided adequate analgesia for longer duration both at rest and on movement when compared to IV paracetamol therapy. TAP block group required less tramadol, so less side effects, and patient can be mobilized early compared to paracetamol group. Paracetamol group had similar pain relief compared to TAP block only in the initial postoperative period, with the disadvantagement of requirement of more adjuvant analgesic in the later postoperative period. These are my references. Thank you.
I am Dr. T. Srikanth, Kattur Medical College, Guntur. I am going to present the paper presentation topic. Title is Comparison of Clinical Performance of IGEL with Laryngeal mask airway ProSeal in elective surgery in adults. Coming to introduction, supraglottic airway devices has revolutionized in airway management. These devices sit outside the trachea but provide a hands-free means of achieving a gas-tight airway. The LMA has been well established for more than a decade and is often used when endotracheal intubation is not necessarily required. Both the classic LMA and ProSeal LMA have cough-related complications. High cough pressure in laryngeal mask airways can cause damage to the mucosa on glottic structures and associated with increased morbidity such as sore throat. To overcome the limitations of ProSeal LMA, a new and cheaper supraglottic airway device called IGEL was developed. The potential advantages are compatible with the anatomical structure, easily inserted into the mouth, reduce risk of pharyngeal tissue compression. The objectives of the study are insertion attempts, ease of insertion, airway sealing pressure, fiber optic laryngeal imaging, ease of gas tube replacement, possible complication, blood and laryngospasm. Material and methods. The study was conducted after obtaining approval of the hospital ethical committee and written informed consent from the patient over a period of 1 year at Kattur Medical College, Guntur. The prospective randomized study was conducted on 80 patients, 40 in each group undergoing elective surgery in supine position under general anesthesia with controlled ventilation with the following inclusion-exclusion criteria. Inclusion criteria: ASA class 1 and 2, age in between 20 to 6 years. 60 years of either sex, elective surgical procedures of duration 1 to 1.5 hours. Exclusion criteria: patients with risk factors for difficult airway, any known pulmonary and cardiovascular diseases, risk of aspiration. Done using statistical package of social science. Mean and standard deviations were calculated for numeric data and expressed as mean plus or minus standard deviation, and for non-numeric data, frequency and percentages were calculated. In order to compare the mean values of two groups, two-tailed unpaired t-test was used for association between two attributes like age of incision, number of attempts, airway sealing of quality score, fiber optic score, region, number of attempts of gastric tube incision, complication occurred in both groups. Chi-square test or F-square test were used. Results: comparison of incision time in seconds between two groups. The mean incision time in group 1 is 12.3 seconds, and in group P was 13.82 seconds. The p-value is 0, which is statistically significant. Comparison of mean airway ceiling pressure in water between two groups. The mean airway ceiling pressure for group 1 is 23.925, and for group P is 29, and the p-value is 0, which is statistically significant. Few advances in anesthesia have had such a dramatic impact as the introduction of the classical laryngeal mask airway, increasing the armamentarium of airway management. This was the first really effective alternative to face mask or tracheal intubation for airway maintenance during anesthesia. The risk of aspiration with classical LMA is reported to be around 6 to 9% as detected by observations of the esophagus via fiber-optic bronchoscopy or low pulmonary compliance requiring peak inspiratory pressure greater than 20 centimeter water. PLMA was introduced in 2000 to improve performance during controlled ventilation, safety regarding aspiration, and misplacement of the device tip. High cuff pressure in the laryngeal mask airways can cause damage to the mucosa and glottic structures and associated with increased morbidity such as sore throat. Therefore, to overcome the limitations of ProSil LMA, a new and cheaper supraglottic device called iGel was developed. iGel as a novel, innovative, made up of medical grade thermoplastic elastomer, soft gel-like transparent design to anatomically fit the pharyngeal and structures with non-inflatable cuff and a channel for gastric suction catheter placement.
There's no audio.
Is it struck, madam? The video is struck.
What's the problem?
A1 logics.
A1 logics.
Are you there? A1 logics.
Some problem in the application itself. Even chat to Hall A live is not also going. It's not working.
There's a technical problem. I will call them.
Some software, some problems.
What can we do now?
Just a minute, sir. They'll sort it out.
Wait, sir. I will.
Edward, shall we call Praveen?
I am calling, sir.
Yeah.
Sir, I think Hall is back now. They are the host now. Probably it should get sorted out.
Yes, sir. Hi, Prasanna.
Sir, how are you, sir? Nice meeting you. Sir.
Fine.
Look, I can start discussion.
So, shall we start the discussion, sir?
Call Vanasuma Sandil.
Yeah, Dr. Vanasuma.
Yes,
so now
sir.
over to judges.
Yes, sir. Thank you.
Good afternoon.
Good afternoon, sir.
Okay, good afternoon, Coordinator Sendil, Kumar.
Good afternoon,
Edward
sir.
Johnson,
Thank you, sir.
Johnson.
Good afternoon, sir.
It was a nice paper.
Thank you,
but
sir.
I want to ask the speaker, what's your aim? Whether it's post-operative pain relief or early ambulation?
Sir, our aim was to assess the home readiness, sir. So how long does both the group take to reach the eligibility criteria for discharge? One is to assess from shifting the patient from post-anesthesia care unit to post-operative ward, from post-operative ward to the home, sir. So overall, home readiness was assessed.
So you are not aiming at pain relief?
Sir, actually, in post-operative ward, we assess the patient using PATS criteria, sir. That is post-anesthesia discharge scoring system. So in that, pain is also one of the components, sir. We assessed pain using VAS score also. So any patients with uncontrolled, more than moderate pain was treated with parenteral analgesics, and the minimal and mild to moderate pains were treated with oral analgesics, sir.
Okay, well, what was the pain relief in both the group, in chlorprocaine and bupivacaine group?
Sir, actually 13 patients in chlorprocaine group experienced more pain in the post-operative ward, sir, compared to only 2 patients in bupivacaine group. So this was statistically significant, sir, actually.
So pain free was
more
pain relief was more in bupivacaine group.
Yes, sir. Yes, sir. Observation was
but
like that.
Your aim is to compare the
early
ambulation.
Yes, early ambulation and also micturition and overall home readiness, sir.
So you are not bothering about the pain relief?
Yes, sir. Those patients with more pain, we didn't discharge those patients, sir. Actually, we made them stay there only. So after ensuring adequate pain control only, we discharged the patients, sir. So actually, pain assessment was not the main criteria.
And then how do you manage the pain relief in chlorprocaine group?
Sir, in chlorprocaine group, actually we used tramadol, sir, IM tramadol for pain management, and all 13 patients were fine after IM tramadol, sir.
So that was not needed in the bupivacaine group?
Yes, sir. It was like only 2 patients in bupivacaine group required IM tramadol.
Okay. Instead of using 0.5% bupivacaine, you could have used 0.25% bupivacaine. That would help in the early ambulation.
Sir, actually, it was not available in our hospital, so we
0.25% bupivacaine is available all over India.
0.25, yes, sir. Sir, actually, we used hyperbaric 0.5.
You could have compared that 0.25.
Yes, sir, we could have done, sir. It was not there in the earlier literature also. We could have done that.
If you would have done the study with 0.25 with your chlorprocaine.
Yes, sir. Then we could have matched even the volume also.
Yes.
In our study, we couldn't match the volume because we used only 1.5 cc of bupivacaine compared to 4 cc of chlorprocaine.
Just 0.5% bupivacaine will be the muscle paralysis will be presenting for a long time. So 0.25 will be muscle paralysis will not be that amount for 0.5. You would use 0.25.
Yes,
okay.
Sir.
That is my suggestion. Over to Prasanna.
Good evening, sir. Good evening, Ganesh Prabhu, sir. Good evening, Kumar, sir, and Sandil Kumar, sir. Very nice meeting you here. And I have 2 questions for the presenter, Ms. Gowda. The first question is, what is the difference between chlorprocaine and bupivacaine? What is the fundamental difference between these two?
Sir, both are local anesthetic, but chlorprocaine is ester local anesthetic. Bupivacaine is amide local anesthetic, sir. And the duration of action, chlorprocaine is short-acting local anesthetic. Bupivacaine is long.
Can you tell some chief contraindications of chlorprocaine to chlorprocaine?
Sir, chief contraindications will be like any presence of atypical plasma cholinesterase or deficiency of plasma cholinesterase is one of the contraindication.
Have you included that in your exclusion criteria?
Yes, sir.
Okay. And secondly, bupivacaine, you told it is a longer-acting drug. What is the point in comparing a drug of amide group?
Yes, sir. But here we have chosen the low dose of bupivacaine, sir, 7.5 mg. So hence we decided to compare with chlorprocaine, sir.
So bupivacaine, for information, it has got a very narrow range for enhancing both the faster recovery and providing effective analgesia. When you start decreasing the dose, the chance of increasing analgesic requirement or supplementation is more.
More, sir.
You told one patient spinal anesthesia failed, but you never mentioned it in your results. What did you do to that patient?
Sir, we excluded that patient, sir. Hence,
Should not exclude. It is not allowed. Okay, that shows that your study is not rigorous. When you do a rigorous study, you should account for each and every patient to prevent randomization. Once the randomization is done, the patient never drops out from the study. You cannot leave a study. Suppose there is a problem, there is something which you don't like, you cannot allow the patient to drop out of the study. That is another issue. And finally, in your results, you told the difference of recovery is around 80 minutes. So how much cost you want to save by discharging the patient 1.5 hours earlier? See, when you mention something in your primary objective, right? You told it is cheaper, right? So definitely you should mention something about it in your results. You should have done a cost analysis, and definitely you should not make any statement in your results that is not part of your study. You cannot make assumptions. Okay, so when you tell it is cost effective, it is cheaper, the patient goes home early. So that definitely you should include some cost analysis study, or else you don't make that statement, right?
yes,
Did you register your trial in CTRI?
Yes, sir. It was registered, sir.
Okay, thank you.
Thank you, sir.
Doctor, should be concentrating more on the pain-free rather than discharging the patient earlier. Okay.
Yes, sir. Yes.
Patient should be pain-free. Ultimately, our aim is patient should not be feeling the pain.
Yes, sir.
Instead of discharging early. Okay.
Okay, sir.
Thank you.
Thank you, sir.
Okay, sir. Shall we move on to next presenter, Dr. Rasmi?
Yes, sir. Yes, sir.
Good evening, all judges.
Doctor,
yes, sir.
Why do you compare a procedural plan with a drug? You should compare a procedural plan. That is tab block along with erector spinal block and other. Why do you want to compare a procedural block with a pharmaceutical block, pharmaceutical pain relief?
Sir, since routinely we have used paracetamol for post-operative analgesia, we were thinking if this is better, then maybe this could be employed regularly. Rescue analgesia, anyways, we give tramadol 2 mg per kg body weight. So we were thinking like to make this tab block like all lower abdominal surgeries, like to make tab block like mainstream, like as we give post-operative paracetamol infusion, sir. Like that, we thought like we can, in case this study proves effective, we thought like we could make tab block also mainstream, like giving paracetamol also.
What's the duration of tab block? What's the duration of paracetamol pain relief?
Sir, tab block duration, it lasted up even at rest and during movement also. The VAS score was 4 or less than 4 in tab block only, sir. Up to 24 hours to 26 to 28 hours, tab block was very effective in relieving the pain. Whereas in paracetamol, in our study, it was almost even at rest and during movement also, it came up to 3 to 4 hours, or maximum up to 5 to 6 hours. Sir.
So what's the difference in hours?
Sir, it is almost like 10 to 12 hours difference.
10 to 12 hours.
Yes, sir.
Then you should go compared with another nerve blocks. Nerve blocks. No.
Okay.
So such a large difference, you should have compared with another nerve block. That is my opinion. If you go for a paracetamol, you could have gone for another drug, non-NSAID and the more.
Okay.
So fundamentally, you could have compared with a nerve block with another nerve block.
Okay.
That should be ideal. Thank you. Over to Prasanna.
Yes, sir. Good evening.
Good evening, Dr. Rashmi. Have you heard something like that's what exactly what sir was asking? Have you heard something like a PICO? What is a PICO approach when you design a study? What is a PICO? PICO. Have you ever heard that term? Fine, okay, no problem. When you compare something, when you want to compare something, it should be against the gold standard, not paracetamol. Okay, it should be at least some NSAID or some other, just like exactly sir told. That is one thing.
Okay, sir.
Secondly, your inclusion criteria mentions you have taken patients who are undergoing emergency LSCS.
Yes, sir.
Is it possible? Is it acceptable? And which category of LSCS patients you took up?
Sir, ASA 2E categories of emergency LSCS.
I'm not talking about ASA grading at all.
Yes,
What are the categories of emergencies? How will you classify cesarean section based upon the urgency? There are 4 classes, right?
Yes, sir.
So how did you, if a patient is already in pain or they might be in labor, did you talk about the VAS? Did you ask for informed consent? Did you get the patient signed? Did you have time to do all this? Frankly, honestly, you should answer. Okay, anyhow.
The consent for procedure was taken from all cases, sir. No, nothing related to consent. Since in emergency LSCS, in any cases where there is fetal distress or anything, we did not attempt. Like all emergency LSCS, obviously we did not attempt. Sir. Sorry that I have not mentioned that in my exclusion criteria.
And what type of emergency LSCS did you take up?
Sir, emergency LSCS where there is failure to progress that are posted as emergency sections. Only failure to progress cases we had taken up.
You don't take emergency. If you want to take, these are all called vulnerable population, right? Pregnant mothers who are undergoing emergency surgeries. So
yes,
whatever you ask for, they will agree. So that is one thing. And secondly, you mentioned about tab block. Okay, what tab block did you give? What are the types of TAB blocks? What are the various type of tab blocks?
Sir, ultrasound guided tab block we had given.
Ultrasound guided. What are the sites you can give a tab block?
Sir, we had taken mid-axillary line between iliac crest and the...
What is it called? Okay, have you heard something like a posterior tab block or lateral tab block?
Yes, sir.
Which is better, posterior or lateral? And there is a phalansteal incision. Which block is better? We have very clear evidence for these things. You need not do a study to find out. Studies are clearly shown posterior TAP is better than lateral TAP.
Yes.
When you do a lateral TAP, it has no meaning. Secondly, you told some complications. Suppose after the surgery, especially with some edema and all, if the drug goes into the muscle, what do you expect? If it doesn't go between the muscles, you have injected some drug into the muscle, what happens?
Sir, since ropivacaine, there are very rare instances of cardiotoxicity or neurotoxicity or any toxicity complications with ropivacaine. So that is the reason we had chosen this cardiostable drug, sir.
See, fine. Local anesthetic are myotoxic. When you inject local anesthetic into a muscle, the cells are going to die. The muscles are going to become paralyzed, and the patients will have post-operative muscle weakness. That is one thing. When you do a lateral TAP block in a cesarean section patient, if you don't
sorry to interfere, sir. The time's up. Please move on to next.
Okay, fine. Okay, fine. I think that's my last question, sir. Thank you, sir.
Please.
So one thing I want to tell to the audience. So when you are comparing two things, you should be when you are comparing a nerve block, you should compare it to the another nerve block. When you are comparing a drug, you should compare to the another drug. Don't compare with the nerve block with a drug. That is my common request to all the viewers. Thank you.
Thank you, sir. So next, Dr. Srikanth Tadangi.
Sir, good evening, sir.
Sir, I think this presentation is incomplete, sir. Has he finished, sir? Last.
Yeah.
Okay.
So A1 logistic, please finish the.
Judges, do you want the slide to be represented again?
No, sir. Only the final slide, if possible, should be fine, sir. Last final results.
Yeah. I don't know whether they will be able to fast forward.
I am Dr. Srikanth, Kattur Medical 2000. To improve performance nil significant. Prokdaj et al. Studied the success rate at first attempt to overall success and failed in session between IGEL and Procil LMA. In our study, the IGEL group 37 by 3 by 0 by 0 patients, and in Procil LMA group 30 by 10 by 0 by 0 patients had a score of 1 by 2 by 3 by 4 respectively. with a p-value of 0.034, which is statistically significant. Conclusion, we conclude that IGL is comparable to Procil LMA in securing the airway during controlled ventilation. It is better than Procil LMA in terms of ease of insertion with less airway ceiling pressure, providing better ventilation and effectively conform to the perilaryngeal anatomy. Despite the lack of an inflatable cuff, it consistently achieved proper positioning for supraglottic ventilation. Thank you.
Doctor, what's your aim of study?
Sir, I am going to compare Procil LMA with IGL, sir.
Regarding ease of insertion?
Number of attempts, air ceiling pressure, sir. Fiber optic viewing.
So number of attempts regarding IGL, how many attempts you encountered?
Sir, out of 40, 37 in first attempt, 3 are in second attempt, sir.
Okay, regarding Procil?
Regarding Procil, 35 in first attempt, sir. 5 in second attempt, sir.
So only 2 cases are different, huh?
Yes.
Okay. Huh? Wow, what is the incidence of ease of insertion?
Ease of insertion, 13 minutes, 13 seconds in IGL, sir. 15 seconds in Procil, sir.
So just 2 seconds difference, nah? Okay, that also doesn't make much a difference. What's a protective mechanism in the terms of aspiration of gastric contents in IGL? In Procil LMA, we can suck it out. What is the protective mechanism in IGL?
Sir, IGL and Procil both have a gastric tube drainage, sir. But IGL have a less air ceiling pressure. Less airway ceiling pressure, sir.
Airway ceiling pressure. So, what is the incidence of trauma when comparing to IGL and Procil? Trauma to the larynx.
IGL has a less incidence of trauma, sir.
You have compared that? Have you compared that?
IGL has a less trauma.
Less trauma. Trauma means in the you would have compared in the
non-inflatable, sir.
Pardon? You should have compared in the post-operative period. Incidence of sore throat, and able to swallow. Did you compare that? Huh? Hello? Hello? Hello?
Yes, sir.
The incidence
sir,
of trauma.
I have compared in post-op.
Did you compare that? Huh? Did you compare in the post-operative period?
Sir.
Did you compare that in the post-operative period, incidence of trauma?
Yes, sir, compared, sir.
Hello?
Last incidence in IGL, sir.
Okay, well, what is the basic mechanism for that?
Because of the non-inflatable, that it does not cause trauma to the mucosas, sir. And also there is a vascular structures and neural structures is not compressed by the IGL, sir. It is a soft structure, non-inflatable structure, sir. It is suitable to the anatomical structure of the pharynx, perilaryngeal structures.
Okay, over to Prasanna.
Okay, just only one question. You showed something like a P is equal to 0.000 in the results. Unless you type exactly the same value in both the columns, P value will never be 0. If it is less than that, you should mention P less than 0.001. Okay, you should not put 0.0. If you say P 0 means, that means both are equal. And if I remember correctly, one tabular column you told 23.9 and 29, but still you showed the P value was 0. I think there is some statistical error from that side. I think we should go through it. Okay. Thank you.
Thank you, Ganesh Professor and Prasanna sir. Now we move on to next session. Start with Sri Harida Sidabadula.
I'm Dr. Sri Harita. The topic for paper presentation is attenuation of the cardiovascular responses to laryngoscope and intubation, a comparative study between IB bolus espural hydrochloride and lithium. Endotracheal intubation has become an integral part of anesthetic management and critical care of the patient. Laryngoscope and tracheal intubation-induced pressor responses have been associated with increase in the catecholamine levels. The rise of these catecholamines are associated with elevation of the blood pressure and heart rate. Though these changes are short-lived, they may have detrimental effects in high-risk patients, especially those with cardiovascular diseases. The aim of the study is to compare the effectiveness of attenuation of cardiovascular response to laryngoscope and intubation between espural hydrochloride and diltiazem. A clinical comparative study was conducted on 90 patients posted for elective surgeries selected randomly. This study was done for a period of 18 months. General anesthesia was provided with endotracheal intubation for all the patients. The inclusion criteria included the patient scheduled for elective surgeries, aged between 20 to 50 years of both sexes, ASC grade 1 and 2, and Mallampati grading 1. Exclusion criteria included unwilling patients, emergency surgeries, anticipated difficult intubation, patient with ASA grade 3 or higher, patient with cardiovascular diseases, patients on beta blockers, calcium channel blockers, and patient whom laryngoscope is prolonged or difficult. Patients were selected after thorough pre-anesthetic assessment and investigations. Informed consent was taken from all patients. 90 cases were divided into 3 groups with 30 cases each. All the patients were pre-medicated with alprazolam 0.5 mg orally at the night before the surgery. On the day of the surgery in OT, IV access was secured. All the monitors were connected, pre-medicated with midazolam and fentanyl. Pre-induction heart rate, systolic and diastolic blood pressures were recorded. All the patients were and action inflate 0.2-0.6% and
The audio is not clear.
Sir, I think Holly got
A1 logistic. A1 logistic.
per kg. Descriptive data presented as mean plus or minus standard deviation and in percentage. Pairwise comparison between the groups was done by t-test. These are the trends of systolic, diastolic, and mean arterial pressures where the espular group has better attenuated the hemodynamic response. In the present study, the heart rate was increased more in the control group compared to diltiazem and espular, and in heart rate reaches a level which is clinically less significant by the end of 10 minutes in control group and by end of 3 minutes in diltiazem. Cardiovascular changes associated with laryngoscope and intubation, like drugs, age, type of procedure, depth of anesthesia, hypoxia, hypercarbia. They influence the hemodynamic response. The most important laryngoscope factor influencing the cardiovascular response is found to be the duration of laryngoscope. In our study, the duration of laryngoscopy and intubation was limited to 20 seconds. The IV infusion of diltiazem is effective and safe in treating sinus tachycardia in critically ill patients and used to prevent intraoperative ischemia in ischemic heart disease patients. It is also very effectively attenuates the cardiovascular responses to tracheal extubation. It is recommended to use at the dose of 0.2 to 0.3 mg per kg IV. Optimal time for administration is 2 minutes before laryngoscopy and intubation and 2 minutes before tracheal extubation. Espanol is a beta-blocking drug with several desirable properties. Cardioselective ultra-short-acting espanol makes it well suited for controlling the cardiovascular response to tracheal intubation when used as a continuous infusion technique. A single alternative is using bolus dose of espanol, and many studies have investigated this and concluded to be efficacious. Conclusion: the patient achieves pressures and statistically and clinically very high, and espanol significantly attenuates the sympathetic response to laryngoscope and intubation. Espanol is more effective than diltiazem in attenuation of sympathetic response to laryngoscope and intubation. These are references. Thank you.
Next presentation,
Good evening,
please.
everyone. My topic for paper presentation is a prospective randomized comparative study to evaluate a long axis, short axis, and medial oblique axis approach for ultrasound guided internal jugular vein cannulation. Introduction. Internal jugular vein cannulation is commonly performed in the axis rate, cannulation time, and reduced mechanical complications. USG guided technique has three approaches: short axis, long axis, and medial oblique control difficult. Long axis can optimize needle visualization, but it is challenged to perform. Medial oblique approach tries to take advantage of both short axis and long axis by placing a probe in between short and long axis and combines it with in-plane needle insertion in which the needle is advanced from lateral to medial. Aim of the study is to assess and compare the performance of these three methods. This study was designed as a prospective randomized controlled trial conducted after obtaining ethical committees of either sex of age 18 years or above scheduled for elective surgeries were included. Exclusion criteria includes infective signs, subcutaneous hematoma, subcutaneous emphysema, recent cervical trauma with neck immobilization, uncooperative patient, or thrombus in IGV. The patients were allocated into two groups: Group A short axis, Group B long axis, Group C medial oblique axis using randomized method. After connecting standard monitors and intravenous line, all intubated were put into trend line by 20 degree with towel under the shoulders and head onto opposite side for cannulation. The cannulations were done using 7-French triple lumen catheter. With short axis, the transducer is placed transversely over the neck, and once the vein was visible, needle was introduced in a plane perpendicular to the long axis. In short axis, the transducer was placed longitudinally over the neck, and once the vein was identified, needle was inserted from the footprint of the probe from its long axis from cranial to caudal. With oblique axis, first the vein is identified using short axis approach, then long axis used for needle insertion from lateral to medial. Once the needle tip was insertion of needle to crossing second marker of guide wire, catheterization edge time from insertion of needle to end of the catheter placement, and complications were noted. Results totally 75 patients were randomized between August 2020 to October 2020. The demographic profile of age, sex, and place of cannulations were not statistically significant. The venous cannulations and catheterization characters, the first pass success rate was highest in medial oblique axis, 94%, followed by short axis, 88%, then long axis, 76%, but it was not statistically significant. The mean venous axis time was shortest in medial axis, followed by short, then long axis. It was statistically significant between long axis and short axis, between long axis and medial oblique axis, and but not significant between medial oblique axis and short axis. Guide wire insertion time and catheterization time were also shortest for medial oblique axis. It was statistically significant between the three groups. The complications were minor with carotid puncture 8% in long axis group, and incidence of arrhythmias in short axis group for 8%, followed by long axis and medial oblique axis. The discussion: real-time ultrasound guided IGV cannulation has become the standard of care and is recommended for numerous societies. The main objective is to compare these three approaches for our USB guided IGV cannulation and as to which scanning axis provides optimal condition for vascular access. Butler et al. Compared these three approaches in 220 patients and noted high first-pass success rate in short axis compared to long axis. In contrast to our study, the incidence of carotid artery puncture was less in long axis as compared to short axis. Baldia et al. Conducted the study between short axis and medial oblique axis and found first attempt success rate was higher in medial oblique axis as compared to short axis, and it was statistically insignificant. But they conclude medial oblique axis position for IGV to be superiority over the other approaches. In the study, we found that medial oblique axis and short axis are better than long axis in terms of short venous access, guide wire, and catheterization time, and also high first attempt and with overall success rate with lesser incidence of complication as compared to long axis, though it was not statistically significant. Medial oblique approach has shorter guide wire insertion time as compared to short axis. So conclusion, we conclude that medial oblique approach is a safe and effective approach for performing USB-guided cannulation because of better visibility of both artery and vein and continuous real-time medial visualization. So we recommend this approach to be encouraged. Thank you.
Next presentation, please.
So next is discussion.
Dr. Niranjani. There is one more presentation. Dr. Niranjani has to present.
Proportion of surgical patients with undiagnosed obstructive sleep apnea using stop-band score. Introduction. Obstructive sleep apnea is a common sleep disorder characterized by episodes of apnea or hypapnea during sleep, resulting in hypoxemia and hypercapnia. The obstructive apnea or hypapnea is caused by a complete or partial closure of the pharyngeal valves. Among the general population, undiagnosed obstructive sleep apnea may be associated with increased mortality as well as morbidity. Undiagnosed obstructive sleep apnea patients may present a variety of perioperative concerns. They have a higher incidence of difficult intubation, post-operative complication, increased admissions to intensive care unit, and longer duration of hospital stay. Our aim is to assess the proportion of surgical patients with undiagnosed obstructive sleep apnea using stop-band score. Inclusion criteria: patients in the age between 20 to 60 years prior to elective surgical procedure. Exclusion criteria includes patients with upper airway disease, non-epileptic, patients who are on any sedatives, patients below 20 years and above 60 years of age. The study type is used as prospective observational study with a sampling size of 70 patients, and the methodology used is simple random sampling. Stop-band questionnaire includes 8 questions with a history of snoring, feeling tiredness, observed gasping, choking or any apneic episodes, high blood pressure, BMI more than 35, age more than 40 years of age, neck size more than 40 centimeter with male gender. If the patient answers yes, it will be given a scoring of 1. If the patient answers no, it will be given as 0. The stop-band score is categorized into 3 categories: low risk, intermediate and high risk. Low risk with a score of 1 to 2, intermediate risk with a score of 2 to 4, and high risk with a score of 5 to 8. The response of the patients are recorded in the form of table, and the risk of developing obstructive sleep apnea is recorded in the form of pie chart. Result: in 70 patients, the percentage of surgical patients with low risk of developing OSA are 15 patients. With intermediate risk of developing OSA, count of 31 patients. The high risk of developing obstructive sleep apnea is 24 patients. This pie chart shows low risk categorized as 1 to 2, 3 to 4 is categorized as intermediate risk, and 5 to 8 as high risk. Conclusion: about 78% of surgical patients with increased risk between intermediate to high of developing obstructive sleep apnea is identified using stop bank question. This study method can be used to identify the risk of undiagnosed sleep apnea and to prevent perioperative complications. Thank you.
Thank you, presenters. Now move on to discussion. Request for judges. Already we are running short of time. Request you to reduce the time within 10 minutes. Thank you, sir. Thank you, sir.
Okay, I will discuss. My discussion time will be very short. Don't worry. Okay. For the first speaker,
Yes, sir.
it is not ideal to compare alpha and beta blocker with another calcium channel blocker. See, their mode of action is very different of alpha and beta channel beta antagonist. The mode of action of calcium channel blocker is mode of action is different. So you cannot compare these. Basically, you cannot compare these two. If you want to compare esmolol, you can compare with Indrall or labetalol and all. Okay, that should be ideal one. This is my basic. What's the answer for you from you?
I just took as they are both
See, mode of action is very different. Calcium channel blocker. Diltiazem is a calcium channel blocker. You could compare diltiazem with verapamil. That should be ideal. And the mode of action is different. You cannot compare both. That's maybe a basic doubt. What are you going to answer for that? Why do you want to compare between the two different mechanism of actions?
I just want to compare which is more, which attenuates more, sir.
Okay, actually, alpha, your esmolol will be ideal. That is more obvious. Alpha and beta channel antagonist will be more ideal. That will be a very obvious thing. Okay, over to Prasanna.
Yes, this is mainly, I would like to restrict my comments now only to the methodology because already you are running short of time. How did you randomize your patients?
Sir, just randomized at 1, 3, 5.
Oh, see, there are certain words which you used which are very wrong. You told patients are randomly chosen. Patients are never randomly chosen, they are recruited. You apply inclusion and exclusion criteria, you select patients properly, and then you randomize by a known method, preferably either in blocks of 3 or blocks of 5. But I think most of you should have underwent that mandatory program for postgraduates regarding research methodology by ICMR. Anyhow, your randomization and patient selection, it should be very clear, it should be very explicit. And those are my only comments. Thank you.
Okay, regarding the second speaker, I want to know which is the ideal approach and why.
Sir, actually, there is nothing called ideal approach since all these three approaches have certain advantages and disadvantages, sir. So by comparing these three, we conclude that medial oblique approach has high first pass success rate and guide-wide time and catheterization time. So approaches.
So you want to compare the ease of approach or success of the approach?
Both, sir. The ease and success.
Okay, which one is best? Hello?
Medial oblique axis, sir. A medial oblique approach proves to be better than the other two, sir.
Number of attempts, number of failures.
Yes, sir. Actually, the failure in these three approaches, there was no failure, but the first pass success rate was higher in medial oblique approach. Out of 25, 24 were cannulated in the first attempt itself, whereas it was 22 in short axis and 19 in long axis. And the guide wire time and catheterization time were also shorter in medial oblique axis approach, sir.
Okay, good.
Thank you, sir.
Thank you.
Okay.
Thank you, sir.
Why there are no images in your presentation? Why there were no images, ultrasound images? Okay, that is one. And secondly, what was the primary? Yes, what was the primary objective of your study? It's just I'm rephrasing sir's question in a different way. What is the primary objective of your study?
The primary objective is to find out which approach is better, which means in terms of venous access time, guide wire time, and catheterization time, and the first pass success rate.
Too many objectives. You should have only one. It should be a very clear-cut objective. See, primary objective is a parameter. It's a number. It's going to be a number, right? So, did the same person did all the cannulations?
Yes, no, that is more important. Huh?
The same person did not perform all the cannulation, right? So, there is
yes, sir.
Fine. Next is, if the person who is performing the cannulation, did he know that his time is being monitored?
No, sir.
I mean, what is the importance of time actually here? This quicker cannulation leads to better outcomes. If I do cannulation in 3 minutes, or I should do cannulation in 30 seconds. So, first of all, it should be anyhow.
Okay, sir.
Next, you told about incidence of arrhythmias. Does it differ with your, why you should differ with your approaches? Is it going to differ? Because arrhythmia is going to happen once the guide wire reaches your right atrium or something, right? Why did you specifically monitor the incidence of arrhythmias? I think there is some bandwidth error. Fine, I think we can go ahead with the next discussion, sir.
Okay.
Yes, sir.
Third one.
Next.
Good evening, sir.
Regarding the obstructive sleep apnea, what is the medical management for that?
Medical management includes if a patient whose BMI is more than 30 kilogram per meter squared, drugs like phentermine or statins can be used, sir. Since phentermine is an stimulant, the appetite center will be suppressed. So patients can be given phentermine and statins, sir.
Okay, I'm not asking about the weight reduction. I'm asking about the patient has got a severe snoring in the night. So what will you advise?
Head up position, semi-recumbent position, sir, during sleep, so that the obstruction can be reduced.
Any instrument, any equipment you will...
CPAP, use of CPAP will reduce the further obstruction, sir.
Okay, what's the real cause of sleep apnea syndrome? What's the real cause?
Patients with obstructive sleep apnea, during sleep, the upper airway tone will be lost, sir. So, patient will have an episode of hypoxia with apnea. So that patient will have a history of snoring, and which further stimulates the causes autonomic stimulation. Hypoxia will make the patient awake. When he is awake, the upper airway tone will be resumed, so that his breathing will get resumed automatically, sir.
Okay. What's the additional factor? Whether it is related to obesity? Whether it is related to obesity?
Yes, sir.
How?
Whether obesity is related to obstructive sleep apnea, you are asking, sir. Yes, patients who are obese will have edematous swollen airway, sir. So automatically patient will obstruction of the pharyngeal walls will occur, sir. So patient will prone for episodes of apnea, sir.
So soft tissue enlargement in the posterior pharyngeal wall and the airway, upper airway.
Yes, sir.
What's the real surgical treatment for that?
Bariatric surgeries can...
Bariatric surgery for... Hello?
The questions gets difficult. The bandwidth will come down, sir. The question's difficulty is inversely proportional to the bandwidth.
No, where is she?
So gone.
Yeah, sir, Rakshita here.
Sir, I think that student delegate is, PG delegate is not, yeah, she is joining.
Gone with the wind.
Sir, if you ask easy questions, I think it will stay longer.
Just I want to know, what is the surgical treatment for sleep apnea? Again, she has gone.
Again, it can't.
Niranjani? Niranjani is the name?
Yeah, it's a Niranjani.
Where is she?
It's, I think.
Yeah, Niranjani, what is the surgical
Uvuloplasty, sir.
Pardon?
Uvuloplasty.
3UP.
Uvulo. I'm not sure, sir.
3U-plasty.
Okay, sir.
What is that? What's the surgical treatment? What is the precaution we have to take as an anesthetist?
When we give anesthesia for obese patient, we should have a proper pre-operative anesthetic planning, sir, because patients will be prone for difficult mask ventilation, difficult intubation during induction of anesthesia. Patient will have a airway obstruction following an extubation, post-operative complications, and they have a strict venothrombotic event should be avoided. And those patients are more prone for some cardiopulmonary disease. So analyze proper pre-operative planning is necessary while posting a patient for anesthesia, sir.
The surgery is U3P, uvulopalato-pharyngioplasty.
Pharyngoplasty. Okay, sir.
Uvulopalato-pharyngioplasty. So more of soft tissue will be in the posterior pharyngeal wall. First,
Yes,
we
sir.
have to do the nasal septal correction. That should be one of the things, obstruction in the airway. Then next step will be excision of the posterior pharyngeal, tonsillectomy and the excision of the uvula and the soft tissue. So everything should be excised. The thing is, you should not. It is gone again. You should not give so much of narcotic during the surgery.
Yes.
Okay, that is the main thing, because if again narcotic
Post-op respiratory depression.
Post-operative respiratory depression will be there. So that thing you have to keep in our mind.
Yes, sir. Thank you, sir.
Prasanna?
So once again, I would like to focus only upon methodology, because that is one important fact that you should learn. I mean, what is your sample size?
70, sir.
Can you decide the incidence is 38% if you take just a sample size of 70? And how long did you take to finish this study? It is simple questionnaire. It is like a survey, right?
Yes, sir.
When you decide, you say this is incidence, you should take the entire patients coming for an year or so, or at least in thousands. Then only you can say the incidence is 38%. So your study is not a study, simply it is a survey. We should have taken hardly 5 to 10, I mean maybe around 5 or 10 days. Next is, did any of the patients in your study, did they have any complication? Because you were chosen surgical patient. Complication post-operatively? Did you observe? You told so many complications, right?
Yes, sir.
Complication, did you encounter any complication in the post-operative period?
Yes, sir.
Why it was not part of your study? Okay. Fine. My main concern was either about the sample size. You cannot conclude it is 38% by taking 70 patients. Just by asking question to 70 patients, you cannot decide the percentage of 38 or so. You need more numbers.
Okay, sir. Thank you, sir.
So, no more discussion. We will finish it up. Its session. Thank you very much, Ganesh Prabhu sir. Thank you very much, Professor Prasanna Vadanan sir. Nicely discussed and gave all the valuable points to the students. Thank you very much, sir. Thank you once again. Now, I hand over this session to next coordinator, Dr. U. Radhika. Thank you, one and all.
Thank you, Sendil. Thank you, Selvakumar.
Thank you, sir. Thank you, sir. Thank you, Prasanna, sir.
Thank you, Selvakumar.
Sir, you can send the score sheet to...
Yeah, yes, sir.
What's his mail ID?
I'll send you, sir. I'll send you.
Okay, okay.
Thank you, sir. Thank you, everybody.
Thank you. Thank you, Prasanna.
Yes, sir.
Shall we start, sir?
Good evening, Ganesh Professor. Hi, sir. Hi, Selva, sir.
Oh, யாரு?
Nagalakshmi.
ஓ, நாகலட்சுமி. எப்படி இருக்க?
நல்லா இருக்கேன் சார். நல்லா இருக்கேன் சார்.
சரி 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 சரி. உங்க புதுச்சேரி மீட்டிங் தான் வர முடியல எனக்கு.
ஆமா சார். ஆமா. நல்லா போச்சு சார்.
ஓகே ஓகே ஓகே.
Good evening, one and all. I am the coordinator of this session, Dr. U. Radhika. First of all, I welcome our judges, Dr. P. Nagalakshmi and Dr. Umesh, sir. Let me introduce them. Dr. P. Nagalakshmi is Associate Professor in Pondicherry Institute of Medical Sciences. Her areas of interest are airway management, pediatric anesthesia, regional anesthesia, and she is the organizing secretary of Airway Update 2017 and ISACON Puducherry 2020. Presently, she is holding the position of Secretary ISA Puducherry, and she is a regular faculty of the state level conferences and CMEs. And next, Dr. Umesh, sir. He did his UG in KMC Mangalore and postgraduate in AIMS New Delhi. He is currently professor in Department of Anesthesiology, Timhans, Dharwad. He published more than 80 publications in international corporate journals. His important research works are intubation director, EO technique of mask holding, arterial line for SQ2 monitoring, and he is associate editor of Indian Journal of Anesthesia, and is field medical director for Operation Smile India. Let me go to the presentation. Our first presenter, Dr. Abhinaya Ratnavelu. She will give her presentations now.
Good evening. I'm Dr. Abhinaya from Conclave Medical Center, Coimbatore. I'm presenting an audit on perioperative complications in patients on clopidogrel undergoing non-cardiac surgery. My guides are Dr. Chalaya and Dr. Arun Kumar. Inopyridine antiplatelet drug indicated for acute coronary syndrome, stroke, and peripheral vascular disease. According to ACC/AHA guidelines, aspirin, a lifelong therapy, should not be interrupted before surgery. Dual antiplatelet therapy is recommended 2 weeks after simple dilatation, 6 weeks after bare metal stents, and 12 months after drug-eluting. All elective operations should be postponed beyond these days. Patients having angioplasty and stent for peripheral vascular disease remain on therapy throughout. Patients with surgeries with high risk of bleeding like intracranial surgeries, spinal surgeries, intrathoracic intra-abdominal surgery, major orthopedic surgeries should be discussed with specialists regarding stoppage of clopidogrel. Therapy resumed 24 hours postoperatively. According to ASRA guideline, the recommended time interval between discontinuation of clopidogrel and neuroaxial blockade is 5 to 7 days. Therapy is reinstituted immediately after catheter removal or 24 hours postoperatively. Clopidogrel is a double-edged sword. If continued perioperatively, there is increased risk of surgical bleeding. If stopped perioperatively, there is increased risk of vascular thrombosis. The purpose of this audit is to find out the incidence of inadequate stopping of clopidogrel, incidence of adverse perioperative bleeding, incidence of blood product usage, incidence of vascular thrombosis when clopidogrel is stopped. The audit was conducted as a prospective observation of 100 cases. All patients on clopidogrel for varying indications posted for non-cardiac surgeries were included. Preoperative details included like type of surgeries, dose of clopidogrel, whether it was combined with aspirin, indication and duration of treatment, number of days clopidogrel was stopped before surgery. Intraoperative details included were time duration of surgery, if it was mild, moderate, or severe intraoperative bleeding, and any blood transfusion required during intraoperative period was noted. Postoperative bleeding was observed until the drain was removed or until the postoperative day 3. Only 46 cases out of 100 stopped clopidogrel for recommended 5 days. Out of the total 100 cases, 4 had excessive intraoperative bleeding, and no cases had excessive postoperative bleeding. First case was a 95-year-old male posted for laparoscopic cholecystectomy under general anesthesia. He was on clopidogrel for 10 years for ischemic heart disease, and he withheld clopidogrel for past 3 days before surgery. It was a prolonged surgery due to presence of adhesions, and excessive bleeding was noted. No postoperative bleeding was observed. Patient was hemodynamically stable and blood products were not transfused. Second case was a 65-year-old female posted for low anterior resection under general anesthesia. She was on clopidogrel and aspirin for 10 years for ischemic heart disease, and she had severe LV dysfunction. She stopped dual antiplatelets for 6 days before surgery. Excessive intraoperative bleeding was noted, and 1 pack cell was transfused. No postoperative bleeding was noted. Third case was a 65-year-old male posted for a transforaminal lumbar interbody fusion at 2 levels, L2, L3, L4, L5, and a GA. He was on dual antiplatelets for ischemic heart disease. He stopped antiplatelets for 2 days before surgery. Intraoperative bleeding was excessive, and 1 unit of pack cells and 2 units of platelets were transfused. No postoperative bleeding was noted. 69-year-old male posted for VP shunt under general anesthesia. He was on dual antiplatelets for just 10 days for ischemic heart disease and stopped treatment 2 days before surgery. It was an excessive intraoperative bleeding, and 6 units of platelets and 4 units of FFP were given. No significant postoperative bleeding was observed. Preoperatively, as a prophylaxis, 2 patients required 4 units of platelets transfusion, and intraoperative bleeding was not that significant. Only 15 cases were done under neuraxial anesthesia, and no spinal and epidural hematoma were observed postoperatively. Types of surgeries included amputation, split skin grafts, laparoscopic hernia, open hernia surgeries, renal transplants, major replacements like hip replacements, knee replacements were done. TURP, TURBT were included under the study. ENT procedures like FES and mastectomies were included. Spine surgeries like TLIF, ACDF, laminectomies, transsphenoidal pituitary tumor excisions were also included under the study. More than half of the patients, like 54%, had elective surgeries before stopping clopidogrel for the recommended 5 days. 4% had excessive intraoperative bleeding. None of the patients had excessive postoperative bleeding, and none of the patients had any vascular thrombotic event during that hospital admission. Intermediate and high bleeding risk surgery should be done only after stopping clopidogrel for 5 days. Restart clopidogrel 24 hours postoperatively. The decision to stop clopidogrel should not be taken lightly. It should be taken only after consultation with the cardiologist, surgeon, and anesthetist. The patient should be informed of the higher thrombosis risk on stopping and higher bleeding risk on continuation of clopidogrel. Thank you.
Our next presentation,
Good
Dr.
evening,
Ritika
I'm
Swami.
Dr. Ritika from Sri Ramchandra University, and my topic is to compare the efficacy of preloading the endotracheal tube cuffs with agonized lignocaine and endotracheal tube cuffs loaded with agonized lignocaine after intubation and attenuation of postoperative hoarseness of voice in surgeries of shorter duration, a prospective randomized study. Hoarseness of voice has been a very common complication and complaint after endotracheal intubation in patients, and this has been very limiting to patients with an incidence of about 16 to 55%. Various methods have been taken in order to minimize the effect of the postoperative hoarseness of voice, and the effect of agonized lignocaine with endotracheal tube cuffs on the postoperative sore throat symptoms and hoarseness of voice has been well proved in our literature. Clinical studies have proven that agonized lignocaine takes minimum of 90 minutes to start diffusing out of the cuff membrane, and complete diffusion takes an end of 300 minutes. Natt et al. In 2018 studied that the effect of reloading the endotracheal tube cuffs with agonized lignocaine 90 minutes prior to intubation, and proved that it was effective in attenuation of emergent cough during extubation in surgeries of less than 120 minutes. The aim of my study was to study the efficacy of preloading endotracheal tube cuffs with agonized lignocaine 90 minutes prior to surgery and its effect on the hoarseness of voice in surgeries of shorter duration. The study was taking place in the Department of Anesthesiology, Pain Medicine, Sri Ramchandra Institute of Medical Science and Research Institute, a prospective randomized double-blinded study with a sample size of 80 patients. My inclusion criteria were ASA 1 to 3, age of 18 to 60 years, and surgeries less than 120 minutes. And my exclusion criteria were any underlying respiratory tract illness, preoperative change in voice, airway surgeries, and patient denial. Total 94 patients were taken into study, out of which 90 patients completed our study. They were randomized by computer randomization method into 2 groups, Group P and Group L. In Group PL, they were preloaded with the study drug, that was 8 ml of 8.4% sodium bicarbonate and 2 ml of 2% lignocaine. The cuffs were checked for any tear or leak, and adequate care was taken in order to prevent any damage of the cuff. damage or contamination of the cuff or the endotracheal tube. Before the procedure, the study tech was discarded from the cuff, and the cuff along the ET tube along with the covering was taken into the operating room. In group L, the ET tube switches minimally access to opening the packings, and the ET tube's cuff switches checked for any tear or leak. The ET tube along with the covering was taken into the operating room once our patients were moved into the operation theatre. In both our groups, all the patients were connected to the ASA standard monitors, and we had a standardized induction policy and expression policies in both the groups. In the postoperative period, the patients were assessed for hoarseness of voice. This was done by a 4-point graded scale at 5-time intervals. That was at 10 minutes at post-extubation, the 2nd, 6th, 12th, and the 24th hour post-extubation. And the scale ranged from grade 0 to grade 3. Grade 0, where the patient had no complaint. And in grade 1, 2, and 3, the patient had minimal change in voice, moderate change in voice, and severe to gross change in voice, respectively. In coming to the results and statistics of our study, most of the patients came across the age group of between 35 to 40 years of age group, and the BMI of most of the patients were between 21 to 22. While comparing the duration of surgeries and the volume of cuffs in both the groups, there was no significant difference between the two groups. Most of the surgeries were within 45 minutes of duration, and the most common volume needed in the endotracheal tube cuffs post-intubation was about 5 ml. While comparing the hoarseness of voice in the post-operative period, in group PL, where preloading was done, in the 10th minute post-extubation, about 75% of the patients did not have any hoarseness of voice in the post-operative period, and which gradually increased. And by the 2nd hour, only one patient in group PL had hoarseness of voice. In the 2nd, 12th, and 24th hour, none of the patients in group PL complained of any hoarseness of voice. The incidence of hoarseness of voice was higher in group L compared to the group PL, but the severity of the hoarseness of voice was also less in our group L. By the 2nd hour in group L, 73% of the patients reported no sore throat. And by the 12th hour in the group L, 97% of the patients reported no sore throat. There have been various studies that have been proved efficacy of arrhythmias technique in the post-operative sore throat and hoarseness of voice symptoms. And various methods such as lidocaine spray, jelly, ketamine nebulization gargle have been studied and proven efficient in attenuation of post-operative hoarseness of voice. But the method of preloading the endotracheal tube cuffs, arrhythmias technique, and its effect on post-operative hoarseness of voice has not been studied yet. And we need to do more studies to compare the other standard proven methods to reduce the post-operative hoarseness of voice in comparison to the efficacy of preloading the cuffs with arrhythmias technique in attenuation of post-operative hoarseness of voice. I conclude my study saying that preloading the endotracheal tube cuffs with arrhythmias technique significantly decreases the incidence of hoarseness of voice in the post-operative period in surgeries of shorter duration.
Next presentation, Dr. Mantri Sangeet Kumar Suresh.
Good evening, everyone. I am Dr. Sanket Kumar Mantri. My presentation topic is study of knowledge, attitude, awareness of brain death, organ donation, and organ transplantation among the clinical postgraduate student at Rural Tertiary Care Center, Loni. Potential organ donor is defined as the presence of either brain death or any catastrophic irreversible brain injury that fulfills the brain death criteria. Every day, the demand of organ is increasing. Near about 1 lakh people died per year are potential donor, but 200 actually becomes organ donor. The attitude of healthcare specialist is utmost important for maintaining the chain of organ donation, organ transplantation. Hence, we conducted a study among the clinical postgraduate medical student in Rural Tertiary Care Hospital, Loni. Materials and methods. A cross-sectional questionnaire-based study conducted among the postgraduate medical student in Rural Tertiary Care Hospital, Loni. Postgraduate student of all the 3 years of clinical departments were the part of the study. Anonymity and confidentiality of responders were maintained and participation was voluntary. Ethical approval for this study was obtained from Institutional Ethical Committee. A survey included 29 questions, which is divided into four parts. The first part include personal data of postgraduates. Second part include variability of the knowledge. Third part include attitude of the postgraduate regarding brain death, organ donation, and organ transplantation. And fourth part are related to awareness among the postgraduates regarding brain death and organ donation. In results, a total 120 postgraduate residents participated in the questionnaire prepared. In 120, 61 were male and 59 were female. Amongst the segment knowledge, about 82.5% of the residents were able to diagnose brain death, and 10.8% were confused regarding the proclaiming the patient as a brain death. In knowledge regarding green corridor, 67% residents know about green corridor in organ transplantation. Near about 81% of the residents know that there is a law related to organ transplantation in India. 96% residents are ready to promote organ donation in our hospital, and 73% residents are ready to donate their organ after death. But 20% of the residents are confused regarding decision. A 70% donation is a noble act. Most of the patients in our hospital are related to road traffic accidents, and 72% residents consider the same. Regarding the team guiding for organ donation and team for organ transplantation, as such, we do not have any team regarding this, but near about 34.2% and 58.3% residents confused regarding the team guiding for organ donation and team guiding for organ transplantation. For discussion, for successful organ donation and transplantation, awareness amongst them on the knowledge attitude of the people it caters, and it hence postgraduates has an important task to educate and motivate the people. However, lack of proper education negatively influence the organ donation. In Darlington et al., there is a huge lack of knowledge among the medical concept was in adequate range. A study done by Al-Nazar H.A. et al. Shows that 55.8% ready to donate their organ after death. But in our study, 73% residents ready to donate their organs. Success can be achieved only if the postgraduate residents are well educated about the organ transplantation and brain death declaration. Another approach is to promote the organ donation is by prompt identification of suitable brain dead donors, which requires the trained intensivist. In our study, 82.5 postgraduates were confident of being able to diagnose brain death. In our study, 70% postgraduates knew that the blood group compatibility is necessary for organ donation, and this was found to be lower as compared to study conducted by Sindhu et al. Awareness regarding the retrieval of organ and guiding team for organ donation is negligible in postgraduate students. To save the life by organ donation, attitude towards the organ donation and transplantation is very important factor. In our study, higher percent of postgraduates that consider organ donation is a noble act and are ready to promote organ donation and to be a part of counseling team regarding organ donation. In conclusion, despite of appreciable knowledge, there is a deficit in the awareness regarding the organ donation among the postgraduates. So necessary step has to be taken to improve the same at rural setup. After that, postgraduates can be taken initiative to promote the organ donation. These are my references. Thank you.
I request our judges to answer questions.
So the first candidate is there, Dr. Abhinaya Ratnavelu. First presentation. Is she there?
Yes, ma'am. She's.
I couldn't see you.
Okay, next Ritika Swaminathan.
Is she available?
Huh?
Hello.
Yes, doctor.
Yeah. Ritika is there, right?
Yes, ma'am. I'm here, ma'am.
compare the efficiency of preloading the endotracheal cuff with alkalinized lignocaine, right?
Yes, ma'am.
So what are the problems you faced post-operatively?
There's no much problem I faced post-operatively.
Extubation. During extubation, were you able to deflate the cuff as easily as you used to do with air?
No, ma'am. There it was not that easy, and we had to deflate the cuff step by step.
How did you do that?
Ma'am, we first wait for the patients. We follow the extubation criteria, ma'am. And so once the end tidal agents was less than 0.2 Mach and patient was conscious, obeying our commands, and there's adequate head lift and hand grip, we're giving reversal for the patient, ma'am. And once adequate tidal volume was also achieved, we first removed half the cuff, ma'am. And so how was the patient breathing, ma'am? And if we felt there was no much edema, laryngeal edema after half the cuff was removed.
How did you measure laryngeal edema?
We measure the tidal volume difference between inspiratory and expiratory, ma'am. If there's anything, if it is more than 100, if there's a the tidal volume difference was more, ma'am, or there's no tidal volume. Sorry, when there's no tidal volume difference, it will be suspected in edema. So we were careful during extubation.
Okay, it's something similar to the leak test.
Yes, ma'am. It's something that's protocol we followed for this study, ma'am.
For this, okay. What is your primary outcome?
Ma'am, a primary outcome was see any post-operative hoarseness of voice in patients, ma'am.
At what level? I mean, what was the time frame?
Ma'am,
what
first
point
after,
of time?
Once the patient was fully conscious, we shifted to the PACU, ma'am. After arrival of the PACU, after 10 minutes, we first asked the patients for any hoarseness of voice, ma'am. Then at the end of 2 hours, before the patient left the PACU, ma'am. And then at 6 hours, 12 hours, and 24 hours, the patients are followed in the respective wards, ma'am.
Where did you find the significance, exact significance between
the until the 6th hour, my preloaded group had very good significance, ma'am, compared to my not preloaded group. But after
when
that,
you graded, when you graded, what level did they fall into? Group 0, 1, 2, 3?
Ma'am, most of my patients had only in preloaded group had only grade 1, ma'am. Very less patients had grade 2 or grade 3.
What about your control group?
Ma'am, in my group B, where there was no preloading, also the severity of hoarseness was lesser, ma'am. It was like grade 1 and grade 2.
Okay.
There's no grade 3 much reported in my study, ma'am.
In all the groups, even
yes,
in control group?
Hardly 1 or 2, 3 or 4 patients in the entire study population had grade 3 and grade 3, ma'am.
What was the rescue?
We had no rescue, ma'am.
At any point of time, did you measure the cuff pressures?
No, ma'am. We didn't use any cuff pressure.
I feel cuff pressure is a much better indicator. If you keep the cuff pressure somewhere between 30 and 40, then the hoarseness of voice will be lesser, more than all these things. If you can keep the cuff pressure, or if you can limit the cuff pressures to somewhere between 30 and 40 with any air, saline, lignocaine, whatever. So if you can limit it, then the incidence of postoperative hoarseness will be less. Because all of the cases which you had only grade 1 or grade 2.
Yes.
And you had no rescue, right?
Yes, ma'am.
Yeah. So you should have measured the cuff pressures at any point of time.
Okay, ma'am.
That's it. Fine. Otherwise, sir, Umesh, sir.
Umesh, sir. Kindly start your video. Can you start your
Hello,
video?
sir. Umesh, sir.
Am I audible now?
Yeah. Yes, you're audible.
So kindly start your video, sir.
Hello. Hello.
It's audible. Audible. Yeah, you can go ahead, please. If you have any questions, please ask, sir. I think so.
Hello, am I audible?
Yes, audible.
Yes, sir. You're audible now, sir. You can ask a question, sir. If possible, can you start your video, sir?
Dr. Umesh? Are you online?
Dr. Umesh, sir?
Yeah. If Nagalakshmi can start the next candidate, I think.
Yes, sir. Yes, sir. Who's the
Next candidate, Dr. Mantri.
Mantri is there, right? Yeah.
Yes.
Can you define brain death?
Good evening, ma'am.
What can you define brain death?
Ma'am, brain death means there should be the absence of brainstem reflexes, positive apneic test.
What is it? I couldn't hear you properly. Can you please repeat?
Ma'am, absence of brainstem reflexes with more than two absence of brainstem reflexes and with positive apneic test.
What is positive apneic test? How do you do that?
Ma'am, in this test, when we disconnect the patient from ventilator, and after that we see after 8 minutes. At the start, we give 100 oxygen to the patient, and after that, after 8 minutes, we see the pH, PaO2 and PaCO2 of the patient. If there is a rise in 20 mmHg of PaCO2, then it is positive, ma'am.
To do something, you know, for apneic oxygenation, do you do something? Oxygenation has to be full, no?
Yes, ma'am.
So do you do something for apneic oxygenation?
Ma'am, we give 100%.
That is at the start, right? That is at the start.
Yes, ma'am.
During disconnection phase, what else do you do? What is the prerequisite? Okay, don't mind, leave it. Okay, fine. Good presentation. Is the other candidate available, Abhinaya?
Thank you,
Abhinaya? Dr. Abhinaya? I think she's not available now. Okay. Shall we go to our next presentation?
Yes, please. Yes, please.
Next, Dr. Selvakumar Gay. Presentation of Dr. Selvakumar.
1 minute.
Good evening, sir and ma'am. My topic is to evaluate the clinical presentation, management, and outcome of patients with COVID-19 in ICU.
Can I please interrupt?
Can I please interrupt? Pandemic in early 2020 with more than 61.5 million cases, more than 1.44 million deaths.
You raised your hand. Nagalakshmi, ma'am.
No, the presentation is not audible. That's why.
Madam, Dr. Umesh sir is now available on phone. Can we connect to Umesh sir?
Yes, please.
Yes, sir can join now. We shall start the video. Yes. A1 Logics, please start the video. Selvakumar's video.
Good evening, sir and ma'am. My topic is to evaluate the clinical presentation, management, and outcome of patients with COVID-19 in ICU. Introduction: the COVID-19 disease led a global pandemic in early 2020 with more than 61.5 million cases, more than 1.44 million deaths as of November 2020. In India, more than 9.31 million cases and more than 136,000 deaths as of November 2020. The initial published report of COVID-19 described the most common presenting symptoms as fever, cough, and dyspnea. I compared the patient with COVID-19 recovered to disease patient to evaluate the clinical presentation management of outcome of patients with COVID-19 in ICU. Aim and objective: to evaluate the clinical presentation, management, and outcome of patients with COVID-19 admitted in ICU among recovered and disease due to COVID-19. Location: Department of Anesthesiology, IRCU. Methodology: a retrospective cohort study. Study duration 6 months. Participant: patient admitted in ICU with COVID-19 positive. Methodology: after institutional ethical committee clearance, a retrospective cohort study was conducted. to evaluate the clinical presentation, management, and outcome of patients with COVID-19 admitted to the ICU in Kanyakumari Government Medical College. I included the patients who are all admitted in ICU with COVID-19 positive from April 2020 to October 2020. Analysis explained to patients COVID-19 outcome status, independently reviewed the documented clinical presentation and management of all patients. Sample size is 177. Inclusion criteria: COVID-19 positive patient with one or more than one organ failure. Exclusion criteria: refusal to treatment, left out to other hospital. This is our institutional protocol for treatment. Asymptomatic patients receives hydroxychloroquine, azithromycin, zinc, vitamin C, and paracetamol. Methylprednisolone and enoxaparin given to who are requiring oxygen with CT suggestive of pneumonia. Remdesivir given with to the patient CT suggestive of pneumonia with LFT, RFT normal. For tocilizumab, if inflammatory markers are elevated, given. This is our institutional protocol for oxygen therapy. If on arrival saturation is less than 94%, patient started on simple face mask. If saturation not improving, patient switch over to non-rebreathing mask. If saturation not improving, patient switch over to high flow nasal O2. If high flow nasal O2 ROX index is low, patient switch over to CPAP or BiPAP. In CPAP or BiPAP, patient is still hypoxic or hemodynamically unstable. Patient switch over to mechanical ventilation. Parameters monitor: demographic data, symptoms, comorbidities, and investigation and management. Statistical analysis. Statistics were performed in SPSS Statistics version 23. Descriptive variables were described in terms of means and standard deviation. P-value of less than 0.055 considered significant. Student t-test for comparison of means and chi-square test for comparing categorical variable. Person correlation coefficient were calculated to know the degree of correlation. Result. Enrollment. I enrolled 177 patients. 2 patients are left out. I followed up 128 recovered, 47 disease. Analyzed 128 recovered, 47 disease. In demographic data, all data are comparable except BMI. BMI has statistically significant correlation with disease patient. In comorbidity, CKD and systemic hypertension has statistically significant correlation with comorbidity in disease patient. In symptoms, fever, runny nose, and breathlessness has statistically significant correlation with disease patient. Investigation: lymphocyte count, NL ratio, high CT severity score has statistically significant correlation with disease patient. Mild CT severity score has statistically significant score with recovered patient. Lymphocyte count, lymphocytopenia presented in disease patient. NL ratio, high NL ratio presented in disease patient. High CT severity scores present in disease patient. In management, CPAP and invasive ventilation has high significant statistically significant correlation with disease patient. NRM therapy has statistically significant correlation with recovered patient. Although remdesivir is statistically significant, CKD patients with high renal parameters not receive remdesivir. This graph shows when there is requirement of oxygen increase, the chance of survival will be less. In summary, the BMI, CKD, systemic hypertension, fever, breathlessness, lymphocytopenia, NL ratio, CT chest, CPAP, and invasive ventilation has statistically significant correlation with the disease. Mild CT severity score, NRM therapy, and remdesivir has statistically significant correlation with recovered. Discussion: increased mortality was observed in patients with high BMI and in patients suffering from hypertension and chronic kidney disease. Patient presented with fever and breathlessness indicated poor prognosis. Lymphopenia, increased NL ratio, high CT severity scores was observed in disease patient. Increased requirement of oxygen indicated a poor prognosis. All patients who received intubation did not recover. Strong correlation was observed in NL ratio and number of disease patients. Breathlessness and lymphocytopenia and CPAP treatment showed medium correlation. Low CT severity score and NRM therapy showed medium correlation with better prognosis. According to Cochrane database, ICU mortality is 42%. In our institution, it is 29%. Limitation: as a retrospective study based in single academic medical center and focusing on patient presenting for emergency care, it may not be generalized to other institutions with a different patient population or patient with milder form of the disease. The study design relies on the review of the medical record and thus variation in clinical assessment and documentation, particularly absent mention of symptoms and comorbidity may result in misestimation of the prevalence of the clinical features. Conclusion: as per my study, risk factor for mortality, high BMI, CKD, and hypertension presenting with fever and breathlessness, lymphocytopenia, high NL ratio, high CT severity score, and patient treated with CPAP and invasive ventilation. Favorable factor for recovery includes low CT severity score and treated with NRM therapy. Increased requirement of oxygen indicated poor prognosis. Thank you.
Next presentation, Dr. P. Kanimuri.
A1 Logics, are you hearing me?
Good morning. I'm Dr. P. Kanimali, postgraduate of Training Medical College. My topic is on the comparison of dexmedetomidine nebulization and lignocaine nebulization in blunting the hemodynamic response to intubation, a prospective randomized control study. Introduction. The laryngoscopy and intubation are associated with the transient unpredictable hemodynamic changes, which may precipitate myocardial ischemia, arrhythmias, cerebrovascular stroke, increase in intracranial pressure in the vulnerable group. This response occurs within 30 seconds after intubation and lasts less than 10 minutes. The aim of the study is to compare the efficacy of nebulized dexmedetomidine and nebulized lignocaine as a pre-medication in blunting the hemodynamic response to laryngoscopy. The patients were assessed for eligibility with the inclusion and exclusion criteria. The inclusion criteria includes the age 18 to 65 years, the ASA grading of 1 and 2, the patients undergoing elective surgery under general anesthesia. The exclusion criteria are patient refusal, predicted difficult RV, pregnancy, renal failure, and body mass index of more than 30 kg per meter square. After getting informed consent, the patients were randomized in 2 groups. The group A receives dexmedetomidine nebulization with a dose of 1 microgram per kg mixed with a normal saline to a total volume of 5 ml. And group B receives a lignocaine nebulization, 4 ml of 4% lignocaine mixed with a saline to a total of 5 ml. Each member was received from both groups because of unpredicted difficult RV. In operating room, the standard monitors were connected. Patients were pre-medicated with injection glycopyrrolate 0.02 mg per kg. Pre-oxygenation was done with 100% O2 for 3 minutes. Injection fentanyl was given 2 microgram per kg and was induced with propofol of 1 to 2 milligram per kg, titrated with a loss of verbal response, and the succinylcholine 1.5 mg per kg was used as a muscle relaxant. Intubation was done with an appropriate sized endotracheal tube and was connected to the ventilator. Then hemodynamic parameters were noted at 1 minute, 5 minutes, and 10 minutes post-intubation. The demographic data were comparable, and the heart rate. The graph shows that there was a decrease in heart rate following an intubation, but the decrease in both groups were not significant. Similarly, the systolic blood pressure also doesn't rise above the expected range in post-intubation stage, but there was no significant difference in both groups. The diastolic blood pressure, this graph also shows the same. The mean arterial pressure, there was no significant difference between the both groups who received dexmedetomidine and a lignocaine nebulization in this chart. Then the patient satisfaction was asked post-operatively regarding the cough, sore throat, and the patient reduced anxiety conditions, which was better seen in dexmedetomidine conditions. Results: though the both groups were blunting the hemodynamic response to intubation, but when comparing both groups A and B, there was no statistical difference noted in heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure. All these parameters, the p-value was more than 0.05. Thus, both dexmedetomidine and lignocaine nebulization has an equal efficacy in blunting the hemodynamic response to intubation, with an added advantage of better patient satisfaction in dexmedetomidine when compared to lignocaine. Thank you.
Good morning, all. My paper presentation is about effect of acute non-volemic hemodilution and autologous blood transfusion on hematological parameters in orthopedic procedures and an observational study. Aim and objective: effect of acute non-volemic hemodilution and autologous blood transfusion on hematological parameters in orthopedic procedures. Materials and methods. Study design is a randomized observational study. Sample size: hemodilution group 15, control group 15, total of 30. Inclusion criteria: ASA1 and 2 patients, both sexes, age between 18 to 60 years, elective surgeries under GA. Exclusion criteria: patient refusal, patients with cardiac diseases, uncontrolled hypertension, and impaired renal creatinine in more than 1.5 milligram per deciliter, and impaired hepatic function, serum bilirubin more than 1.5 milligram per deciliter, platelet count of less than 1 lakh, and patient on anticoagulant therapy, and hemoglobin less than 12 grams. Hemodilution technique. In the pre-anesthetic preparation room, hemodilution done by withdrawing 1 unit of whole blood via anticlinal vein into standard blood collection bags with CPDA. Blood is sealed and labeled with patient identification and time of collection, and labeled as untested blood for autologous transfusion only, and harvested blood is stored in the blood bank. Concomitantly, lactated ringer solution is infused to obtain a ratio of 1:3. Hemodynamic monitors also done. Estimated allowable blood loss that equal to estimated blood volume into initial hemoglobin minus target hemoglobin divided by mean hemoglobin, where mean hemoglobin is arithmetic mean of initial hemoglobin and target hemoglobin, where estimated blood volume is 75 ml into body weight for male, 65 ml in the body weight for female. The target hemoglobin level is in the current study is 9 grams and the lowest hemoglobin allowed is 25%. In the hemodilution group, that is group H, all patients were reinfused with their blood in the post-operative recovery room. In the control group, that is group C, allogenic blood transfused with when maximum calculated allowable blood loss was reached. Samples collected are sample P on arrival in the pre-anesthetic preparation room, sample 1 after hemodilution but before induction, sample 2 2 hours after the completion of autologous blood transfusion. Parameters to be measured are hemoglobin, hematocrit, platelets, bleeding time, and clotting time. Demography. In group H, there is 7 male and 8 females, total of 15. In group C, it is 9 male and 6 females, total of 15. In this graph, you can see the mean arterial pressure is reduced both in group H and group C between pre-operatively and post-operatively, but within the normal limits. Heart rate. Heart rate also increased in both hemoglobin group and control group between pre-op and post-op, but within the normal limits. Hemodilution, hemoglobin in group H and group C, there is a fall in hemoglobin between pre-op and post-operatively. And hemodilution group, there is in after hemodilution, there is a fall in hemoglobin level than the group C, but statistically significant in the concentration group C between pre-op and post-op. Hematocrit level also reduced in both hemodilution group and control group between pre-op and post-op. Platelet count is reduced in hemodilution group and control group, but statistically significant in the group H, that is hemodilution group. Bleeding time and clotting time both are increased in group H and group C postoperatively, but within the normal limits. Results. There was statistically significant reduction in the platelet count between pre-op and post-op values of group H. In group C, there was a statistically significant reduction in the hemoglobin and hematocrit between pre-op and post-op values. And in the current study, both groups have shown reduction in hemoglobin and hematocrit postoperatively. And the conclusion is acute thromboembolic hemodilution is safe, elective, alternative for allogenic blood transfusion in orthopedic procedures. Thank you.
Now I request our judges to ask questions.
Good evening, ma'am. Ma'am, I can't hear
Madam,
you.
kindly unmute. Madam, kindly unmute.
Okay, sorry. So is this sir?
Yes. Start.
Is a prospective cohort or a retrospective cohort?
It's a retrospective cohort, ma'am.
Okay. So what did you intend to see, or what did you intend to measure in this prospective cohort?
It is a retrospective cohort. I want to see the risk factor for mortality. What is the possible recovery? So,
how did you arrive at the number 177? Your sample size was 177.
In these 177 patients admitted in IRCU, ma'am. So I take the sample size, ma'am.
There should be a time frame, or in a 1 month period time, or something like that. No, what was the criteria?
Patient for the 6 months, ma'am.
Over 6 months duration.
I
can't hear you. I'm sorry.
Over 6 months duration, ma'am.
Over 6 months period. Okay. So now what is ROX index?
The ROX index is to know the HFNO success and failure chance.
Should we wait, Dr. Radhika?
the participants can stop their video and you only allow the audio to come. If bandwidth is low, video will not come. So you put off the video, talk through the audio. Lakshmi, you can ask a question, ask them to stop the video.
Yes, sir. Yes, sir. Sure, sir. Sure. Sure, sir. Sure. I think he's not there.
He's there. He's there. I'm sending him a request to unmute himself.
Selva Kumar.
Lost the connection.
Doctor, you can put off your video, Doctor. Dr. Selva Kumar. Again, has gone off.
Yeah. It's okay, sir. Fine. We'll go about with the next candidate if it is okay.
Yeah. Radhika.
Dr. Kanimuri, is Dr.
Yes.
Kanimuri there?
Yes, ma'am. Good evening, ma'am.
So how did you arrive at the number 30?
Ma'am, we calculated the sample size based on the formula, ma'am, with the power of audible, ma'am.
Power of? What is that?
Ma'am, we calculated the sample size with the formula with the power of 70%, ma'am, with the confidence interval of 95%, ma'am.
Okay.
And
what is the action of dexmedetomidine if it is nebulized? And how did you arrive at the dose 1 mics?
Ma'am, the dose was arrived based on the previous papers used for nebulization, ma'am.
Okay.
The action was the same as that of IV, ma'am, but with less intensity, ma'am. If you are given in IV route, we will be getting a bradycardia and hypotension immediately, ma'am. There will be reduced bradycardia and hypotension in nebulization.
Did you not face bradycardia in any of your patients?
No, ma'am. No significant bradycardia was seen, ma'am.
There was an increase in the heart rate in one of your graphs. There was an increase in heart rate.
Yes, ma'am.
Was it within the limits, within the 20%
yes,
limits?
Ma'am. Yes, ma'am. Within the 20% limits only, ma'am.
Okay. What is the bioavailability of dexmedetomidine?
Ma'am, via nebulization, the bioavailability is from 75 to 85%, ma'am.
Okay.
By oral, the bioavailability is reduced very much, ma'am. By IV route, it is 85 to 90%, ma'am.
And you told something about better patient satisfaction. How did you arrive at the better satisfaction? What is the scale?
Yes, ma'am. We were asked about the cough, sore throat, and reduced anxiety levels, ma'am. That was better with dexmedetomidine because dexmedetomidine has a sedative property and anti-anxiolytic effects, ma'am.
Okay. Okay, fine. Okay.
Thank you, ma'am.
Dr. Vignesh.
Lakshmi, Umesh sir is online.
Yeah, can you hear me?
Yes, sir.
I'm audible, no? Yeah. This is a study related to nebulization, isn't it?
Yes, sir.
What was your primary outcome variable?
So to measure the hemodynamic outcome, blunting of hemodynamic responses, sir, heart rate and blood pressure, sir.
Okay, so you are not going to tell in conclusions regarding the patient acceptance because your outcome variable and the sample size that you computed was related to only hemodynamic response.
Yes, sir.
Okay, so that should not be part of your conclusion. Other queries are same regarding sample size estimation and how did you decide on the dosage, which madam has already asked. Then we can move on to the next presenter.
Thank you, sir.
Dr.
Hello. Hello.
Dr. Vigneshwaran?
Hello.
Dr. Vigneshwaran, can you hear me?
Yes, madam.
Okay. So your study is on the effect of acute normovolemic hemodilution and autologous blood transfusion in orthopedic procedures, right? So what was the primary outcome of your study? It's an observation, right? You should have defined something which you wanted to study at the starting point of the study, right? So what was that?
It's an alternative method for allogenic blood transfusion.
See, it has been already proved that acute normovolemic hemodilution is a better way. What are the advantages? It is one of the advantages of acute normal hemodilation, right?
And used in rare blood groups.
What is that?
Rare blood groups. This method can be used in rare blood groups.
Rare blood group. Yeah, it has already been proved, right? So why did you have to do this study? Which is already proved.
Orthopedic procedures, and there's a more loss, madam. So you have to use by this method.
What I try to say is you should have some definition or outcome definition to have a study. Proper study should be designed with a proper outcome, right? That has not been there in your study. What was the primary outcome? That is not there. And one more question is, your number was 17, 15 in each group, right?
Sorry.
Why is that? Why did you take it as 15 in each group?
Discussion முடியல செல்வகுமாருக்கு கன்னியாகுமரி.
Inadequate time, madam. So only you can.
சரி, நான் லைன்ல இருக்கட்டும். The judge they want to ask any question to Selvakumar, we'll ask. அதுல பிரச்சனை ஆயிடுச்சா? சரி சரி, கரெக்டா இருக்கட்டும். லைன்ல இருக்கட்டும். விக்னேஸ்வரன் போயிட்டு இருக்கு.
Sir, kindly mute your.
சொன்னேன் again Selvakumar is available னு சொல்லுவோம். Let him wait. நான் ஸ்டார்ட் அடிச்சறேன். ரைட் மேடம்.
Hello, Dr. Vignesh, can you hear me?
Yes, sir.
Yeah, one of the drawbacks of your study is the purpose itself is defeated because it is already well known that acute normovolemic hemodilution is preferable compared to other ways of conserving blood. So because there is no blood transfusion reaction which is likely to happen with other blood conserving techniques. But one thing I did not understand is why did you store this particular blood in blood bank? The whole idea of acute normovolemic hemodilution is to leave that in the theater and use it in the theater. Once you send it to blood bank, there is always a possibility of clerical errors, and it might become a big drawback for the whole purpose that is defeated.
In more than 30 minutes, the RBC, there's a chance of RBC lyse. So
no, you should transfuse that within that period so that the platelets, the FFP part and the coagulant parts of the blood will be best utilized. That is the whole purpose of acute normovolemic hemodilution. Any other questions?
Vigneshwaran, I would like to ask you one thing. See, you said, why did you have to, when sir asked the question, you said that you would like to store the blood in the blood bank because it has to be stored for more than 30 minutes. What does the blood bag contain when you collect blood for acute normovolemic hemodilution? How do you do that?
The blood bag contains CPD.
Then how will the RBC lyse? What is CPDA?
Citrate phosphate dextrose.
Yes, citrate phosphate dextrose and adenosine, right? So then how will the RBC lyse within 30 minutes? How do you collect it?
By the blood collection bag, madam, in hospital, with that blood collecting bag with CPD.
What is the role of agitator in collecting blood? What is the role of agitator in collecting blood? Okay, the take home point is you should collect it and keep it in the theater for use for the same patient. Okay, it will not, the RBC will not lyse, the platelet will not coagulate because it is collected in an agitator. Okay, so how much maximum volume of blood you can collect during one particular period?
Around 350 ml.
No, 350 ml is one blood bag. So you can collect depending upon the hemoglobin of the patient. Okay. Fine.
I didn't hear that he said 30 minutes.
Yes, sir.
Usually within 6 hours you need to transfuse that.
Yes,
Dr.
sir.
Vignesh.
Yes, sir.
Okay.
Yes, sir.
Judges and Dr. Selvakumar, that candidate, Dr. Selva Kumar, has been asked only one question. He is waiting. He is online. If you want to ask any more question, you can call him.
Yes, sir. Yes,
No, he presented about COVID-19 study, no, sir? No, I don't
yes,
have
sir.
any questions to ask about him. But the previous three speakers, I'm sorry, my audio visual, I got into trouble. But I did type some of the queries to Nagalakshmi Madam also and Dr. Radhika also. If they are available, I can ask the queries. Otherwise, it's fine.
Radhika, find out whether Abhinaya is online.
Sir, Abhinaya is not online, sir. Ritika and Mantri is available, sir.
Call them both.
Dr. Ritika Swaminathan.
Can I tell? Selva Kumar, he wanted to answer ROX index. Yeah,
ROX
yeah.
index.
He was halfway through answering. Yeah.
Ma'am, it's is SpO2 divided by FiO2 divided by respiratory rate, ma'am. If more than 12 hours, if ROX index is less than 4.88, the chances of HFNO failure is there, ma'am.
So ROX index will be a better predictor of the requirement for intubation.
The requirement of intubation.
Yeah, CT scores and all. There is a direct correlation between the CT scores and the
disease and recovery.
Fatality rate. Yeah, fatality rate. But ROX index is a better predictor of the requirement for oxygen. Yeah, that if you had studied ROX index, that would have been much relevant in this case.
I studied, ma'am.
That was not there in your study. Okay, fine. You studied, that's fine. Okay.
Thank you.
Dr. Ritika Swaminathan.
Yes, what was her number? Dr. Ritika?
019,
Yes,
019.
okay, fine, right, yeah, thank you. I'm audible now?
Yes, sir.
The question is, how did you conduct blinding for evaluating doctors in this study? You said it was a double-blinded study.
Yes, sir. Sir, I blinded because the anesthesiologist was present in the OT performing the cases, did not know which group the patient belonged to, sir. So once my patient was, the ET tubes were prepared in a separate preparation room. And so, once the patient had wheeled into our OTs, the ET tube will be brought from the preparation room into our respective OTs, sir. So those ET tubes will all have their packings slightly open, sir. So thus the anesthesiologist in the OT will be blinded, sir.
The endotracheal tube into which you had already preloaded the drug, and then you have deflated everything, and then you shifted the patient with the tube into the theater, isn't it? Wasn't the residual part of it visible in the cuff or in the pilot balloon? Could that be some kind of confounding factor? I really don't know. I have not tried this, so I really don't know whether that would become visible or not. I'm asking you.
Yes, sir. It could have been a confounding factor, sir. But
okay,
we try a level best to reduce the blinding, sir.
That's what. How was it done? I don't know. If you are in the theater, you should be knowing whether it was visible or not visible. Could it be recognized or not? And who evaluated the hoarseness of voice in the post-operative phase?
The hoarseness of voice was evaluated by another anesthesiologist, sir. We had another person involved in the study.
Did not know. Okay, fine. That is good.
That person did not know, sir. We had two people involved, both did not know where the patient, the person belonged to, sir.
Once the patient was intubated, did you again inflate the cuff in both the group of patients with the same drug?
Yes, sir. Both the group were had the same 2 ml of sodium bicarbonate, 8.4%, sir.
Yeah, in both groups, same was inflated, isn't it? Same was used to inflate.
Yes,
all right. So how did you check the cuff pressure? Was cuff pressure manometer used?
Cuff pressure manometer was not used, sir. We just oscillatory method, which is heat.
Please mention that as a drawback of the study, because if you don't know how much pressure was used, it is difficult to assess the hoarseness of voice in the post-operative period and compare them.
Okay, sir. Sure, sir.
Thank you.
Thank you, sir.
Then I have comments for 0171 that was related to clopidogrel study. Is that person available?
Sir, she's not available.
Okay, that's fine, ma'am. Yeah, thank you.
Sir, Dr. Sir, would you like to ask questions of Dr. Mantri Sangeet Kumar.
Oh, what was that study about? That is
Brain death.
Brain death criteria.
Yes, sir.
Yeah, one thing I felt, is he there, the presenter?
Dr.
Is he
Mantri?
online? Is he online? I searched.
Yes, sir. He was.
We couldn't find. We couldn't find. I think he
A
has
few
left.
minutes ago, he was online. Okay, sir. Okay, sir.
Okay.
And Abhinaya also
Sorry for
left.
the problem that I created. I'm really sorry.
That's okay, sir. Thank you, sir. Thank you. Thank you, madam. Thank you for your valuable points. Thank you, madam.
I request both the judges to send the score sheet to Dr. Edward Johnson's mail. It is given in the judges group.
Sure, sir. Sure, sir.
Yes, sir.
Sir,
Yes,
it will
sir.
be sent in another half an hour. Yeah, thank you.
Yes, sir. Thank you, sir. Thank you. Radhika, you can conclude.
Thank you. Thank you, sir. Thank you, sir.
A1 Logics?
Yes, sir.
Is that
Yeah, she's.
we can conclude, I think. We are done now.
Hello, sir.
Sudarshan?
சொல்லுங்க சார்.
Almost we are done now.
Yes, very good. அதான் பார்த்தேன்.
We can conclude.
Okay, sir. Thank you. I think on behalf of ISA Tamil Nadu, I thank all the judges who taken and time off and being participated and being fully interactive for the entire sessions right from the afternoon time. I thank immensely all the judges and all the delegates who have participated well and taken a lot of shown interest to present papers and taken the efforts to record the same thing and be present at the time of discussion. And thank you all. And of course, our all controlled Dr. Selukumar sir. He's been wonderful in having this hall under total control under his stewardship. This hall has done very well. And I think it has been a very useful discussion for all the postgraduates and a lot of take-home messages, lot of important suggestions by the judges on your study. So try to modify it and maybe this may be a trial run for you. You will fine-tune your study and present it in future with all the corrections. And I'm sure it will be an excellent learning experience for all of you. And all the sub-coordinators of Dr. Selukumar's team, Dr. Radhika and the earlier other doctors who were all present there, Dr. Shiv Prasad yesterday, and all of you, thank you so much. Dr. Senthil is there. Senthil, thank you. And everybody has done a wonderful job. And Dr. Umesh, thank you, sir. And all the judges, I think we'll close this session. And over to Selva.
Yes, thank you, everybody. Thank you, Radhika.
Thank you.
And we should thank A1 Logics. I think today's network problem was there in Mangalore. So problem in the streaming of videos. Anyhow, we have finished and we thank everybody. Thank you, Radhika. Thank you.